he'll be live, I'll share. Are we live?
No, just a bit.
You'll give us a countdown, no?
It's live. Showing.
Yes, sir. You'll be giving the countdown. Yes, sir. Namita, you can start sharing the video. Now you keep it. Once if you say 0, then you plus the play.
Yes.
Keep it like this. And start from the first, Namita. 4 second.
Yes.
Yes, 3, 2, 1, go live.
Linux Laboratories.
Yes, we are live.
Integrated and excited. Partnering with medical fraternity. Linux is a people and process-oriented global pharmaceutical company. Celebrating more than a decade of excellence in CNS. Linux offers unmatched value in everything we do to doctors, patients, and caregivers. Linux is a top-ranked CNS company, and today the industry is following us. With persistent effort, Linux spreads its wings in dermatology. To make millions look good and feel great. To spread smiles head to toe. To maintain, nourish, and enhance skin health. Introducing the latest, youngest pride of Linux. Linux Dermascience offers endless innovative products like Oxyten, Active MF, BioRite, Acnestol, Protect, Bioskin, Castle, and HiKids. Linux Dermascience needs your care to blossom. Linux Laboratories, Linux Dermascience, live, integrated and excited.
Over to you, ma'am.
Yeah, thank you. So good afternoon to all the delegates who have joined us today for the second NSI skill-based CME on nail biopsy and histopathology. The CME is being organized with the Department of Dermatology and STT, UCMS and GTP Hospital, of which I am a proud part. And we'll be discussing about nail biopsy and histopathology, a lot of work on which has been done in our department over the years. First of all, we'll be starting today's proceedings with introductory remarks by our president, Dr. Sushil Tahilaini. Over to you, sir.
Thanks. Good afternoon, everybody. Importance of nail unit biopsy can't be undermined. I'm surely not exaggerating when I say that every working day we encounter situations where we are not sure about the exact diagnosis of nail condition that the patient presents to us with. It could be a dilemma to differentiate a nail psoriasis from onychomycosis, or a situation where only nails are involved and we are not sure about what affects the nails. More important than this, we also may have to pick up a neoplastic condition. We have to differentiate between a race-related simple melanonychia or a hematoma from a nail unit melanoma. A properly done, timely biopsy could mean saving a digit or even a life. I am proud to present the faculty who have prepared a comprehensive program, right from the site selection for the biopsy, art and technique of doing a biopsy to take the fear out of your minds, instructions for the technician who processes the tissue, typical changes in commonly encountered conditions, clinico-pathological correlation. Also, at the end, the silver lining will be a case-based discussion on how the nail biopsy helped in the management. They have it all on a platter I compliment NSIF team and wish you all a much desired and focused learning experience.
Thank you, sir. Thank you for those wonderful words. I now invite Dr. Archana Singal, Director Professor Dermatology and STD. She is the founder president of Nail Society of India. It was founded in the year 2012 under her able leadership and has grown from strength to strength. Ma'am is the officiating head of the Department of Dermatology and STD, UCMS and GTP Hospital, and also a leading expert in the field of nail disorders. Ma'am, please share your welcome remarks with us.
Thank you, Dr. Chander. Good afternoon, everyone, and I welcome you all on behalf of all the faculty members and residents of University College of Medical Sciences. We are proud to announce that we are celebrating the 50th year of existence of a prime institute, UCMS, which has ranked 7th in the medical college ranking recently. And we have to thank our director principal, sir, Professor A.K. Jain, who himself is a very, very acclaimed academician. NSI, UCMS is incidentally the birthplace of NSI. And so much work has been done from UCMS in last 1 decade that many of our colleagues say that it's the University College of Nail Sciences than the medical sciences. So I really hope that the case series, the skill series, which has been conceived by NSI in this difficult year of pandemic, will be very, very welcoming one by all. And I take this opportunity to welcome Professor A.K. Jain, who is Director Professor and Director Principal of University College of Medical Sciences. Sir, please. Thank you.
Thank you, ma'am. We now invite Dr. Anil Kumar Jain. Sir is Director Professor Orthopedics and Principal of University College of Medical Sciences. He is a leading authority on spinal tuberculosis, a leading academician, founder, editor of the Indian Journal of Orthopedics, which is a very strong peer-reviewed journal. And he's also the Dean Faculty of Medical Sciences, Delhi University. Over to you, sir. Thank you.
Thanks, Professor Chanda and Professor Archana. I'm so very happy that we are conducting this program. And first of all, I would like to welcome Honorable Dr. Sushil Tahilaini, the current president of Nail Society of India. And I just came to know that Nail Society of India was launched many years ago, with the founder president being from UCMS and the Professor Archana Singal as the founder president, and Dr. Chanda as the founder secretary. And I think from then on, Nail Society of India has progressed step after step every year, and has attained this shape. I'm very happy that Nail Society of India is conducting this skill-based CME on nail biopsy and histology in the Golden Jubilee year of UCMS. I think whenever we talk about Golden Jubilee year for any institution, it really a time when we introspect from where we started, how much we have progressed, and now what is our future direction. And I think in that case, I'm feel so satisfied that in this Golden Jubilee year, which has by chance has fallen in a pandemic year, in a pandemic which has come after 100 years, that our Golden Jubilee has coincided with the pandemic year. And I'm so well satisfied that UCMS has contributed immensely even in this difficult year. They have not only contributed to the teaching and training of the undergraduate and postgraduate during this difficult year, but so also has shown exemplary effort in managing COVID in this year. And not only that, whenever an opportunity came in between, when the number of cases has come down to some extent, and they have gone back to the the phase of distributing knowledge to different on different subjects. So we recently had in 15 days ago only, we had some decline in the number of cases from the second peak, and we find that this is the first program immediately afterward where we have started disseminating knowledge on on this important aspect. When I look back my own 45 year in medicine, when I joined as a student of MBBS as a medical science, and then student of orthopedics, a lot of patients with the nail disorder, they come to us, to orthopedic surgeon at first instance with the nail disorder. And we used to send in last 30, 40 years, a lot of them for dermatological opinion. And we realized that probably the answer was not coming from the dermatology experts on those opinions. So patient was being shunted from dermatology to orthopedics and back. But now, in last 10 years, the way nail disorders have been, the thoughts on the management of nail disorders have been well put in the shape, and the protocols of management investigation has been put into the proper shape. And I'm very much aware of the book which has been written by Professor Archana Singal and Professor Chander Grover about the nail disorder. So now, a lot of patients among will get a definitive treatment in these complex nail disorder. So in that, the efforts by Nail Disorder, by Nail Society of India, in putting this difficult unsolved problem into the solution shape is praiseworthy, and I congratulate not only the Department of Dermatology of UCMS, but the Nail Society of India in this direction. I appreciate the efforts by Nail Society of India, and I congratulate the President and other members of Nail Society of India to contribute to the nail disorders. I welcome a lot of UCMS alumni who are part of this program, and I'm sure at the end of this session, each one of us will get benefited. And I'm also looking for some more learning in this side. So I congratulate Nail Society of India. I congratulate team UCMS and team Nail Society of India to spread the knowledge in this difficult COVID year, in a golden jubilee year. So with this, I just simply can say happy learning, and let us continue to spread knowledge far and wide on some of the issues, difficult issues like nail disorder. So thank you very much, Dr. Archana. Thank you very much, Dr. Chanda, and thank you very much, Dr. Sushil, for giving me this opportunity to share some of my thoughts. Thanks very much indeed. Thanks. Over to you, Dr. Chanda, so that you can start the program.
Thank you so much. Thank you, sir, for the encouraging words. And your words have always helped us carry on with our work with zeal and enthusiasm. We also have Dr. Sonal, who's a resident nail pathologist now for a long period of time and an indispensable part of Nail Society of India. With this, I invite Dr.
And
Khushbu.
Dr. Vineet Relhan.
And Dr. Vineet Relhan.
Who is president but UCMS alumni.
And with this, I invite Dr. Khushbu Mahajan to take over today's proceedings as the Master of Ceremonies. Thank you, sir.
So we'll begin with today's session. And so starting with the very basics, we have basics of nail biopsy, so which will be taken by Dr. Vineet Relhan, who's current Vice President of NSI and is also the Associate Professor at Maulana Azad Medical College. Start with this session here. Over to you.
Thank you so much, Khushbu. I'm audible?
Yes, sir. Yes, sir.
And my screen is visible?
Yeah, it's visible.
Yeah. So it's really a very proud moment. I'm the alumni of University College of Medical Sciences. I passed out in 1996, and now see that ma'am has already told it's one of the best medical colleges in India. It's ranked 7th this year, and I think in last 3-4 years it is continuously maintaining it within first 10. And what I alumni it has, and fantastic in US, UK, topmost physicians are from UCMS, and this year also, just as Sir was saying, Principal Sir was saying, UCMS and Maulana's Medical College have shown the way. They've been total COVID facilities, and fantastic work they've done, all our residents and faculty. And thank you so much. I'll start with basics of nail biopsy. And I can't move the slides. Can somebody help? Slides are not moving.
Sir, can you stop it and share again?
Reshare.
Enable editing.
Now full screen. Yeah, moving.
So basically, comprehensive before attempting any procedure on nail, whether it is nail biopsy or any other surgical procedure, you should know the comprehensive anatomy, physiology, neural and vascular pathways. It is very essential, the knowledge of all these. And understanding the function of every component of nail unit is a must for a nail surgeon. And you should have adequate knowledge of nail pathology, what is a surgical technique, what instrument do you require, anesthesia, pre-operative evaluation, and if management of complications if they occur. And even the post-op care after the nail surgery is very important. So nail surgeries are basically used for diagnostic and therapeutic purposes. In diagnostic, obviously the nail biopsies come. So one of the key things for a good nail surgery, including nail biopsy, is adequate anesthesias, hemostasis. These are the prerequisite for good surgery. If you go to give a good anesthesia and good hemostasis, you can do good surgeries. So nail avulsions, nail biopsies, management of ingrown toenails are the common procedures which are performed. Now there are two types of nail surgeries, either diagnostic and therapeutic or basic and advanced surgeries. So in the diagnostic, obviously the nail biopsies come, and in the basic nail biopsies, the nail plate biopsy, nail bed biopsy, nail fold biopsies come. Well, in advanced biopsies, these are nail matrix or complete nail unit biopsy or longitudinal nail biopsy, which is called. They are the procedures. The most important thing is the anatomy. You should be very well versed with the anatomy of the nail. And so there are epithelial structures in nail unit and keratinous structure. The keratinous structure being the nail plate. In the epithelial structure, the matrix is very important. So we have the proximal matrix and the distal or the ventral matrix. We have the nail folds, that is in two lateral nail folds and one proximal nail fold, and nail bed. The nail matrix is the germinate portion of the nail matrix, is the germinative portion, and it is a very specialized structure which lies above the mid portion of the distal phalanx. The proximal nail matrix forms the dorsal nail plate. The distal nail matrix forms the intermediate nail plate, and the ventral nail plate is formed from the contribution from the nail bed. The matrix is the crux for nail formation, and its functional and structural integrity should be maintained during the nail surgery to avoid any permanent nail dystrophy. So if there is a damage to the nail matrix, there would be nail dystrophy. Coming on to the blood supply, the nail unit has a rich blood supply. There is a pair of digital arteries which supply the blood to the nail. They form the digital arteries, they form the arcades. One is the distal arcades, subungual arcade, and the proximal subungual arcade, and one is the superficial arcade. These arteries are extremely tortuous and coiled distally, so it allows them to be distorted without kinking to occlude the blood supply. Again, the nerve supply is also the similar. There are dorsal branches of paired digital nerves. They give rise to cutaneous sensory nerves that run parallel to the digital vessels. They innervate the pulp of the digit up to the margin of the hyponychium. and they play a very important part in the sensory perception that transmits pain, touch, or temperature. Now, the arrangement of nerves is similar to the arteries. The digital nerves run along the digit as paired parallel volar and dorsal nerves, and they just terminate before the distal interphalangeal joints. At the distal interphalangeal joints, they divide into branches supplying the nail bed, tip, and pulp. One important thing is that the index finger, middle finger, and the ring finger fingertips are innervated from the palmar digital nerves as compared to thumb, little finger, and toe tips that are innervated by the dorsal nerves. This becomes important in the type of anesthesia called thecal block, where you can only give anesthesia for index, middle, and ring fingers as they are from the palmar digital nerves. So this is the arrangement of the digital nerves. Now coming on to the very important thing, that is the nail unit anesthesia. Why is there is a need for anesthesia? The nail unit is a very sensitive structure and with large number of free nerve endings. So there is a pain associated with this procedure. So before anesthesia, always check for the history, take a good history rule out history of any allergy to the anesthetizing agent, the lidocaine, bupivacaine, which are commonly used, or you can do an intradermal check. Then you assess for cardiac disease, including heart blocks. So the commonest used anesthesia is lignocaine, the lidocaine. The action is instant, and the duration of action is around half an hour to 2 hours, and with epinephrine it is almost doubled to 1 hour to 4 hours. Bupivacaine, the onset of action is after 2 to 5 minutes, and the duration of action is much longer than as compared to the lignocaine. And ropivacaine, there is a vasoconstrictive action also, and the action is longer. So for nail procedures, lignocaine is one of the best anesthetic agent, and it is the most commonly used one. So nail anesthesia techniques can be divided into the nerve block techniques or infiltrative techniques, and the nerve block techniques are proximal digital block, which is the most commonly used, transthecal digital block, which I was talking about the nerve when I was describing the nerve supply, subcutaneous volar single injection block. Then the infiltrative techniques are ring block, that is a distal digital, and the matrix blocks. So the commonest performed technique is the proximal digital block. So where the anesthesia is given at the base of the digit, at the lateral aspect of the proximal phalanx. So you insert the needle at 45 degree and give around 1.5 to 2 ml on both sides. So important thing is that you should wait for 10 to 15 minutes before the action starts. Okay, you should not be in a hurry that you have given anesthesia and start the procedure. Again, a photograph of the proximal digital block. So the needle is given at around 45 degree angle. You insert the needle, hit the bone, just withdraw with the plunger to see if any blood is there or not, and then insert the infiltrate around 1.5 to 2 ml of the anesthetic agent. Now, a distal digital block or the Win block, its action is instant. So it's a more localized area of anesthesia, and a small amount of anesthetic agent can be given around 0.5 ml. So what is done here is you inject the anesthetic agent about approximately 1 centimeter proximal and lateral to the junction of the proximal and the lateral nail fold. So needle is again inserted at 45 degree angle, and it is directed distally up to the bone. Just withdraw it and inject 0.5 ml of anesthetic agent. You will see the blanching of the folds taking place, and you can give also insert additional anesthetic agent in the proximal nail fold also. So effect is immediate. Other methods of anesthesia include the single injection techniques or transthecal blocks, which I was talking. So what has happened is your hand is supinated, insert the needle through the palmar digital crease. This is a distal palmar digital crease. Insert deep into the flexor tendon and inject about 3 ml of drug. So there is advantages. There is minimal risk to the neurovascular bundle. While in the proximal digital block, the arteries are also nearby, so there could be a damage. But in this, there is no damage, and it can only be used for index, middle, and ringer fingers, as they're at the palmar nerves, palmar digital nerves, they supply till the tips of the the nail unit. But in case of the thumb and the little finger, it is the dorsal nerves. Again, this technique can be modified by volar subcutaneous injection. It's a similar procedure as the transthecal block, but you infiltrate the injection injected into the superficial subcutaneous tissue. So there is less pain as compared to the thecal block. So this is one of the photographs of the thecal block. So we are injecting through the palm of crease. Other blocks methods which can be used are matricial block. It is similar to the one which we gave the intralesional corticosteroids in nail. So the needle at the middle end of the proximal nail fold, just behind the cuticle, 5 to 6 millimeter behind the cuticle, the needle is pushed forward. It hits the bone with the bivalent upwards and slow injection till the lunula and the lunula. There is a blanching in the lunula. And the other is the hyponickel block, which is very rarely used. It is a very painful technique, and it was originally used for depositing steroid injection in the nail bed. So you use a fine needle, 30 gauge needle, into the hyponicum, 1 millimeter under the nail plate, and it is pushed into the nail bed. By fanning motion, the drug is deposited, but it is not commonly used now. Now the injecting technique is the anesthesia part, is the painful part. So there are certain tips to reduce the pain, which are very important. You should inject at a very slow rate. Then warming the solution to the room temperature is another good technique to reduce the pain. Use a needle of a smaller size, which will decrease the pain from the puncture as well as limits the flow of the anesthetic infusion. So there would be that reduces the there is a very less scope of distension. So if you give it rapidly, there would be a rapid distension causing a lot of pain. Then a vibratory head massager can be used over the proximal digits during the injection technique. That also helps in reduce pain. Then most important is a talkesthesia. Talk to the patient. Talk to the patient, and there is a distraction from the patient is distracted from that procedure. Then very anxious patients, you can give fast-acting benzodiazepine. Now use of epinephrine. So there is generally a misconception that in nail surgeries, epinephrine should not be used unless there are contraindications like Raynaud's disease or any vasospastic disorder or arterial occlusions and all. It is safe to use epinephrine, and the advantage include it increases the duration of the anesthesia, the post-operative analgesia is there, and there is vasoconstriction that reduces the bleeding. Now, important point about adding sodium bicarbonate. Now, lignocaine, either as plain or pre-mixed with epinephrine, is slightly acidic solution. It is not at a physiologic pH. So injecting this acidic solution is painful. So you can mix 1 ml of sodium bicarbonate with this solution. So this lignocaine or lignocaine epinephrine solution, and it will buffer it to a physiological pH. But important thing is that once you use epinephrine with it, the vasoconstrictive properties, you should immediately use this buffered solution. It should be used immediately once you buffer the solution. As a buffered solution is, the physiologic pH is there, but epinephrine becomes volatile. So it is not a uniform concentration is not maintained over time. So you should inject it immediately. Now, another important point is hemostasis. So hemostasis can be achieved by either by an assistant who can just press the area, but or surgical glove tourniquet, which is very commonly used. Roller gauze can be used, and surgical glove generally delivers a pressure of less than 500 millimeter of mercury, and it is safe. And you should use for tourniquet for only 15 to 30 minutes, not more than that. So this is one of the technique. I'm just clearing the area, disinfecting the area. Then the proximal digital block has been given. Then this is, I'm very fond of using the roller cotton gauze. I find it very convenient. You can find it very, so single use, it is very good. And just you can achieve a very good hemostasis with this. And this we just tie it, just roll it, exsanguinate it, and tie it at the base of the digit. Other techniques of tourniquet could be, you can use a band sort of thing. This is basically a cut glove, which we from the distal to the proximal end, we take it, and it causes a good hemostasis. Then the best one is if you just use a size 0.5 or one number less than the size of the glove, the patient's hand. So, and just give a nick at the tip of this finger of the glove and just roll it back. So you get a good field, as well as this is a sterile area, total sterile area. Now coming on to the nail biopsy, just a brief about nail biopsy. My other colleagues are covering it in detail. So the instruments which are commonly required are the punches. This is the nail splitter, nail spatula, then fine curve forceps, and this is a very fine scissor, that is a Castrovicius scissors. And you can also require a blade, biparpal blade, and sutures. These are the common required things for nail biopsy. Now, what are the, just before we attempt any nail surgery, or that includes nail biopsy also, you should rule out certain things. That is, the contraindications are, these are relative contraindication: peripheral vascular disease, uncontrolled diabetes, any local suppurative process which is going on. It's a relative contraindication. Treat with antibiotics prior to that. Any disorders of hemostasis and hypersensitivity to the anesthetic agents. Now, it is very important to assess the patient pre-operatively. You should take a detailed history, make a good clinical diagnosis, rule out peripheral vascular disease, bleeding disorders, cardiac disorders, diabetes mellitus. Now, important thing is, before you attempt any nail surgery or nail biopsy, you should discontinue acetyl salicylic acid, anticoagulants, NSAIDs or blood thinners. But there is different school of thoughts also. There are certain some physicians or surgeons who will not discontinue it. They say the risk of getting any thrombotic episode of stroke or something is more if you discontinue the blood thinners. But I usually, in my personal experience, I discontinue it 3 to 5 days before the surgery. Any history of vasovagal syncope, anaphylaxis to local anesthesia should be assessed preoperatively. Discontinue smoking prior to the surgery, and pre-operating imaging, X-rays, ultrasounds, MRI should be performed prior to doing any surgical procedure. Then hematological tests, blood sugars, HIV, HCV, and HBC should be performed prior to surgery. Now, appropriate pre-medication, if the patient is very apprehensive, you can give a benzodiazepine, antibiotic prophylaxis, and detailed informed consent, telling the patient about the details of the procedure, how to do it, and what would be the post-operative care should be mentioned. Now, pre-operative instructions for biopsies are very important. I generally tell the patient to scrub the nail with povidone iodine daily during bath starting 2 to 3 days prior to the procedure. Remove the nail polish. Continue all the medications for diabetes, hypertension, or thyroid disorders. They should not come empty stomach. They should wear, suppose biopsy has to be done on the toenails, or any ingrown toenail has to be operated, wear open, wide front sandals, and two should come with attendants. Suppose you are going for an ingrown toenail or certain surgery like that, they may not be able to drive back themselves, so the attendant should be there. Now, coming on to the post-operative dressing is very important. So post-surgical pressure, you should give a post-surgical pressure with a sterile gauze for 5 to 10 minutes. This will secure hemostasis. Then a non-adherent dressing like petrolatum coated gauze, that is a Fairley gauze, should be rolled first. Then cover with a bulky dressing of 3 to 4 layers of dry gauze. Then this should be secured with a roller gauze or elastic bandage. Then a technique of wide dressing is very useful, and this was published in JAD by Dr. Chander and Dr. Ashik. A very simple technique. And important is post-operative, you should ask the patient to elevate or splinting of the fingers or foot elevation 1 to 2 days after surgery to reduce the pain and edema. Dressing should be changed after 1 to 2 days and after 1 week under aseptic condition, and antibiotics and analgesia should be given for 5 to 7 days. Now, important thing, my personal experience is, once you do a dressing is quite bulky, you should try that the finger or the toe tip should be exposed, so you can see the color changes. I have seen few patients, you give very tight bandage post-operatively, and patients have complained of they just miss the bluish discoloration coming up and impending gangrene. So you should always ask the patient that tell you about that if there is a lot of pain post surgery, or if the digit is turning bluish in color. So this is the bulky nail dressing you can, which is given generally, and this is the Y technique. So this is a paraffin gauze cut in the form of Y. So you can just put it, this stem is put it on the plantar surface, and this Y covers this other two ends of the Y. They make a cover the nail unit, then 3 to 4 layers of gauze, then a roller bandage or can be done. Now, what complications are very rare, but you can get pain and swelling, hematoma formation, there could be infection, there could be complete nail dystrophy if you have damaged the matrix. So it should be the complications you should know which can take place. Now, what is the need for nail biopsy? Just our last slide. The nail is capable of projecting only limited number of clinical manifestations. So many different nail disorders may not show. And then there are many nail disorders which show similar clinical features. So you have to do a biopsy to rule out certain conditions. Generally, the nail biopsy is not preferred by dermatologists. These factors could be many. They think it is a complex procedure, the risk of scarring, and reluctance of the patient. But it should be done whenever indicated. Whenever it is indicated, should attempt it. It's seldom it gives scarring. It is seldom. You are very careful, use appropriate size of punch, and don't damage the matrix. It is seldom will lead to scarring. And there are different types of nail biopsy. I'll just mention, details will be covered later. We could do nail matrix biopsy, distal nail matrix biopsy, or approximate nail matrix biopsies, nail fold biopsies, nail bed biopsies, or nail bed assay. Okay. Thank you so much.
Thank you so much. Just one question from the audience, that 1 ml of bicarbonate needs to be added in how many ml of xylocaine?
It should be around half the quantity. I think 2 to 3 ml of this thing is, personally I have never given, but what I have read is around 3 ml of lignocaine solution, you add 1 ml of bicarbonate.
Thank you, sir. Very, very informative and illustrative talk, and I think we understand the basics now. So we'll move forward. Now, most of the times we know that, sir, you need to stop sharing. Thank you. So most of the time we know that we need to do a biopsy, but the problem is how to select the site and how to do a punch biopsy. So we have Dr. Shikha Bansal, who's a professor at VMMC and Safdarjung Hospital, and ma'am, by video demonstration would be helping us understand this. Over to you, Shikha ma'am.
Am I visible and audible? Is my screen visible?
Yes, it is visible and you're audible.
Also. A good beginning is job half well done, sir. So thank you so much for a wonderful prelim to the talk I'm going to present. I thank the organizers for giving me this opportunity to be here. So I'll be talking about a very important topic, which is the site selection and appropriate biopsy site selection. Even if we select the patient properly, we know how to go about doing the technique. But if we don't choose the biopsy site properly, then the pathologist is not going to really tell what the representative pathology is. So by the end of this session, I hope that the learner should be able to select an appropriate biopsy site and be able to confidently perform the punch biopsy procedure. This is probably one of my very few written slides, but I want all audience to listen to this carefully. Please be with me here. So important is nail plate changes on its surface or within are as a result of pathology localized to the nail matrix, which is the root of the nail unit. Second important point is nail pitting or onychorexis biopsy needs to be taken from the matrix rather than the nail plate. Longitudinal pigmented band diagnostic biopsy is to be taken from the point of origin of the band. These 3 points I'll be emphasizing and re-emphasizing during the course of my talk. I just wanted to, for all of you to keep this in mind. This is a very important slide again. Before knowing what to do, we should know what not to do. So these are no-go areas, absolutely. This is lunula distal boundary of the nail matrix. This is proximal boundary of the matrix. And these are the insertion of the extensor tendons. Have a close look on this slide and always remember that these are the no-go areas. And during my biopsy photographs, do look carefully that these areas are always avoided. So coming straight to the point, when to consider nail plate biopsy? For all the beginners here, that's a great idea to begin your biopsy. If you're venturing into the field of performing the biopsy, to start with the nail plate biopsy first. Indications of suspected onychomycosis, suspected warts, nail psoriasis. Disadvantages are it gives limited histopathological data, and there is utility in systemic disease which is reported. There's an article also on that. So nail plate biopsy is easiest and the least scarring. So nail plate biopsy in cases of suspected onychomycosis. This was one of our patients about, say, 2 weeks back. The patient had presented to us with this. This is the onychoscopic view. This is the close-up view on the table. This is the ideal biopsy site. We did only the nail plate biopsy. Please look carefully. After removal of the nail plate, a vascular and undamaged nail bed is visible through the window. Nail plate biopsy in cases of suspected onychomycosis, another case. The reason I showed this was you can take the distal end of the nail plate and do try to include as much of subungual debris as possible. And you might not need tourniquet or local anesthesia while performing this, as good as a simple nail clipping. This was superficial white onychomycosis, a nail plate biopsy for the same. For proximal subungual onychomycosis suspects, yes, you do need a tourniquet and you do need a local anesthesia. Coming to the next, nail bed biopsy. It is to distinguish conditions with similar clinical pattern. For example, onychomycosis and psoriasis, cases with discoloration of the nail bed and any painful nail bed lesion. It can be therapeutic as well. So these are the types. Very important point here is it can be done with or without prior nail plate avulsion. So nail plate with nail bed biopsy in cases of suspected nail psoriasis. Do remember that nail plate harbors a great deal of information in terms of hyperkeratosis, neutrophilic deposits, and the serum crust. So one should try to retain the nail plate. Do not avulse the nail plate and take it along with the nail bed. This was the discoloration and this is the site of biopsy. Again, the distal end of the lunula is respected in this biopsy. Nail bed biopsy with suspected nail psoriasis. Just this was a close-up view. This is the salmon patch which is clearly visible, and this can be a site for biopsy. This was what we did. This was another case in which I kept the differential diagnosis of psoriasis also. So distal onycholysis with subungual hyperkeratosis in both onychomycosis and nail psoriasis. Onychoscopy is definitely done and it does give valuable clues to the diagnosis, and the gold standard still remains histopathological examination. For this patient, this is the close-up view and this is the best site I considered for the nail biopsy. Nail bed biopsy after nail plate avulsion for growth on nail bed. If you can see carefully, there is a bluish discoloration of the nail bed which is there. This is, I did not remove the nail plate. If you can see, there's a vascular tumor and this is after the excision. This is therapeutic. We try to retain the nail plate and put it back as the biological dressing, though it falls subsequently over a period of time. So just reiterating the facts, I would not repeat them again. Nail fold biopsy for paronychial dermatosis or inflammation and nail fold tumors. Important point is, do consider insertion of nail spatula underneath the concerned fold to prevent damage of the underlying nail bed or matrix. This use of nail spatula I do even during my ingrown toenail or while taking other biopsies, because it does help in prevention of the underlying structure. This was the nail fold biopsy for Keenan's tumor. It is excision and therapeutic. This is nail fold biopsy for glomus tumor. Okay, I will briefly touch upon nail matrix biopsy because Chander ma'am will be talking in detail about it, just indicating the site. As you can see, the patient presents with these pittings. So nail matrix biopsy targeting the proximal matrix proximal to the nail pit area showing pits. This is very important. Do not try to biopsy the pit. Nothing is going to come out of it. nail matrix biopsy in a case of onychorexis from proximal nail matrix. Again, it is nail matrix biopsy from proximal matrix proximal to the ridges. Nail matrix biopsy from proximal matrix in a case of tracheonychia in suspected nail lichen planus. This is again a very important fact to know. In this case, I genuinely had a confusion. The patient had chromonychia, had dystrophy, discoloration of the nail plate, and subungual hyperkeratosis. And this was the site of biopsy, and the patient came out to be lichen planus of the nail. This is a case of leukonychia. If you do biopsy from the nail plate in this, then you will get only the parakeratotic retained nuclei. Nothing is going to come out of it. You please do a distal nail matrix biopsy from the area of the nail plate proximal to the leukonychia. In many a case of leukonychia, you can consider doing the nail plate biopsy also in case you are trying to rule out the fungal infection. That is why I had included this along with leukonychia. There is another patient who had his leukonychia in all 20 digits, and in this the biopsy is done from the distal nail matrix. I hope I'm so far clear where to consider a matrix biopsy and where to consider a plate biopsy. So this is true leukonychia nail matrix biopsy taken from the matrix source in the intermediate or distal matrix, and nail plate biopsy can be done to rule out fungal etiology. So nail matrix biopsy from origin of longitudinal pigmented band. This will be talked in great detail by ma'am and by video demonstration as well. Just a quick look through for you all to see the site of biopsy. This is the site of biopsy. We are just trying to show you how the nail longitudinal pigmented band originates. So that is the site of biopsy. This was another case. The only reason I've included this case was, please have a look at the distal end of the nail plate. This might not be a simple longitudinal pigmented band. So the base of the band needs to be dissected to be looking out for origin of the band, whether there is some growth which is lying there leading to this kind of a dystrophic nail plate at a distal end. Okay, now coming to an important second half of the presentation, which is the procedure for the punch biopsy. The advantage is no prior avulsion of the nail plate is needed. And caution, I had told this fact before also, and again reiterating on the same, epithelium of the nail bed is tightly adherent to the ventral aspect of the nail plate, and it can be easily removed while avulsing the nail plate. So if you are doing this rotatory motion with your punch, so be careful that your nail plate specimen does not separate from the nail bed. So whenever you're doing a punch biopsy of the nail, please, two important points you make sure is, if it's a thickened nail plate, you can soak the nail plate in the warm water for some time for the nail plate to soften, one. And second, do not use too much of a rotatory motion by the punch, lest the nail plate separates from the nail bed. Sir had already told about the instruments required, and these are the 4 instruments which are very, very important. I like to use a skin hook. A nail spatula is a must, and I like to use the smaller one, English nail splitter, and Castroviejo scissors. And these are the disposable biopsy punches. How to do a punch biopsy? Simple. These are the photographs I've shown before. Okay, now we have tied a tourniquet, and this is the video. A simple, gentle, rotatory motion suffices. You need not be very hard on it. Please have a look carefully at the forceps, which I've recently got this one, and I find it very useful. I do not use the tooth forceps because it can damage the biopsy specimen. And because I was taking just the nail plate, I did not go very deep. And second, please note, I like to use a 11 number blade to harvest the specimen, but it's your choice what you are comfortable with. So it was quite easy. This is the site, and because I did not go very deep, so this is the clear nail bed which is undamaged, which is visible. So nail bed punch biopsy for a suspected nail tumor. This was a 50-year-old lady who had just presented with pain. MRI did not localize anything. The only reason I'm showing this is for a punch biopsy of the nail bed. This was after the avulsion. That is how you use the punch. And please remember to suture the area post biopsy with the absorbable suture. This was nail plate with nail bed biopsy. We wanted to rule out onychomycosis vis-a-vis nail psoriasis. I would not show the video again because it was the same video as I shown before, but I'll be going a little deeper here. Please note this very important point here, that nail biopsies except tangential excisions need to be taken till periosteum, as there is no subcutaneous tissue in the nail unit. So once you start doing nail biopsy, you'll realize that once you're taking a punch from your nail bed, you hear a very gritty kind of a sound, or you feel that grittiness, which is the punch hitting the periosteum. So please be gentle, and that is the time when you have reached your desired depth. So this is the nail plate as well as the nail bed biopsy. This is a side view, just to you can press the sides of the nail plate so that the biopsy specimen comes up a little. Again, I'm using an 11 number blade to take out the specimen. Here I had gone a little deeper because I wanted the nail bed also. It is very important to tie a good tourniquet. The reason being that once you're damaging the nail bed, then the lesion tends to bleed and the site gets really messy. I do not commonly perform this. I had done this so that I could just sensitize the audience here to another way of a biopsy, which is the double punch biopsy. It should be usually considered in cases wherein there is a growth on the nail bed. The basic, I'll explain what is the basic fundamental behind it. You're using a bigger punch to harvest the, to take away the nail plate, and a little smaller punch for the nail bed. I'll explain. This is the area which is to be biopsied, this discoloration of the nail bed. This is the site of biopsy. As you can see, this is the blanched fingernail. Over the years, I've learned to use this glove finger tourniquet. You just cut the finger of the glove. It is quite effective. As you can see, this is a big punch. This is the 6 millimeter punch, and usually we do not do 6 millimeters on the nail. We just see how easily, just very superficially, I have removed this nail plate because I just want the nail plate to be removed. This is again the forceps I was mentioning, which I like to use. Having good nail instruments is very important. So this is a very clean nail plate which was removed. We'll be using a smaller punch now to take away the, this is the smaller punch, 3 millimeter punch to remove the nail bed. This was post-op. Okay, now coming to the end of my talk, let's do a quick revision of what we have learned so far. So this is the site for the nail bed biopsy. This is nail bed biopsy with after nail plate aversion longitudinal less than 2 millimeters. Please note the axis of the biopsy. It is very important. This is the nail matrix biopsy, distal matrix, horizontal, less than 2 millimeter ellipse. All these points are extremely important. Along with the site, the orientation is also important. This is the proximal nail matrix biopsy from proximal nail matrix after nail fold retraction. These are the lines of retraction. Ma'am will be talking about it subsequently. So coming to, okay, now all ears here, because this summarizes the whole of the talk in terms of determining the site of the biopsy. Obviously, I don't expect you to remember ekdam se, but do have a look here and then you can go back and read the article or the chapters which are there on the same. Pitting or onychorexis area to be biopsied is proximal matrix. Type of biopsy is nail matrix biopsy. Leukonychia intermediate matrix, focal onycholysis, thin nail plate, lunular erythema, distal matrix, longitudinal melanonychia, point of matrix, point of origin of the band, and oil drop, salmon patch, nail bed. We have already seen the sites. Subungual hyperkeratosis, onycholysis, hyponychium, which is the distal area of the nail plate. I had already shown. In cases of crumbling destruction of nail plate, then nail plate biopsy. In total dystrophic onychomycosis, onycholyzed nail plate. Any other dermatosis of a nail folds, nail fold biopsy. We have seen all the examples of the biopsies. So thank you so much for your patient hearing. And it's always good to learn and then apply and then repeat and then learn. If you don't go back and apply this, then you're likely to forget. So turn your knowledge into action. Thank you so much.
Thank you, ma'am. Very, very illustrative and informative talk. Ma'am, there are a few questions. Ma'am, can you please specify the situations where the nail bed can be left unsutured for healing with secondary intention?
I always like to suture, though I take less than 3 millimeters. If it's less than 3 millimeters, then maybe, but there's no harm in putting one suture. It's just one absorbable suture which is there.
Okay, thank you, ma'am. And another question. Please go ahead, ma'am.
No, it's okay. I feel very uncomfortable leaving it unsutured.
Okay. And the next question is how to counsel patient to do nail biopsy? What we explain to the patient. So I think most of it has been covered, but do you want to add something to that?
Sorry, Khushbu, just repeat the first part of the question.
How will the patient do the nail biopsy? And so what can we explain to the patient?
Before the nail biopsy.
So how do you counsel a patient that a nail biopsy has to be performed? So maybe about aesthetics or whatever. So basics, I think Dr. Vineet had covered. Do you want to?
I always talk, first of all, in the local language of the patient, I always talk, don't worry. You can go to your office immediately after the procedure. And in just a minute, my timer is on. Okay, you can always go back to the office after the procedure and the scarring is going to be minimal.
Right. And the last question, ma'am, you mentioned in PSO, we have to give anesthesia while doing even a nail plate biopsy.
Yes, it's going to be very uncomfortable because there are nerve endings which are beneath. You are going to cut through the nail plate and a part of nail bed is going to get little touched upon. So it's going to be very uncomfortable for the patient.
Unless the nail plate is onycholyzed, it is already avulsed. So then you need not give any anesthesia.
Thank you, ma'am. That was all. Thank you so much for a wonderful presentation. So we move on to our next talk, which is again a video demonstration of nail matrix biopsies and other biopsy technique. This would be by Chander ma'am, who's professor at University College of Medical Sciences and also the honorary and founder secretary of NSI. So over to you.
Thank you. Thank you, Dr. Khushbu. Am I audible?
Yes, ma'am, you are audible.
Yeah. So nail matrix biopsy and other biopsy techniques is something that I'm going to cover. Most of the stuff which you can do with your punch has been covered by Dr. Khushbu. I'll be discussing things other than what you can do with your punch. I bring you greetings from Nail Society of India. With
Your
this
screen is not.
My screen is not visible. Is my screen, the slides are moving?
It's
Yes,
visible and slides are moving.
It's visible.
Right, thank you. At the end of this session, we expect our learner to understand the principles behind taking a productive nail biopsy. We need a result out of putting the patient through so much of pain. Choose the appropriate biopsy type and perform it. Operate with confidence on the nail matrix, because that is one area all of us are scared of. And at the same time, minimize the potential side effects or risk of scarring for the procedure that we are going to do. The goal being to encourage utilization of nail biopsy as an aid for well-founded diagnosis of nail disease, because most of nail diagnosis is conjectural, because most of us are scared of nail biopsy. The physicians as well as the patients alike, just reflected by the question which has been just asked. So the objective of a nail biopsy is to arrive at a precise diagnosis of a nail pathology with a simple and safe surgical procedure, avoiding pain and permanent dystrophy. So all these 4 objectives you have to keep in mind if you're planning to do a nail biopsy. Patient selection. Obviously, you don't do a nail biopsy when you can more easily do a skin biopsy. So if the patient has any typical skin lesions, please go ahead with that. Or when you're getting inadequate information on the routine nail investigations, among which I count KOH, culture, and even onychoscopy. Though onychoscopy is not the diagnostic gold standard for most of the things, you have to revert to biopsy, especially when you're considering a tumor or a malignancy. At the same time, the patient should not be having any contraindications, most of them being only relative contraindications, but still you need to be careful about diabetes, especially uncontrolled, any peripheral vascular disease, or any arterial insufficiency. And just as is true with any other surgical procedure, you need to take an informed written consent from your patient, explaining the procedure as well as the patient's options to them in their own language. Various techniques of nail biopsy are just like the various techniques of skin biopsy. Of these, the punch biopsy has been discussed by Dr. Shikha, where all you can use the punch. I'll be talking about the rest of the techniques. As Dr. Shikha has very well outlined, the trick lies in choosing the area to be biopsied, because if you take the biopsy from the right nail, from the right side, the diagnostic yield is very high. That much we can be assured of. So you have so many options when you're deciding to take a nail biopsy, starting from the least scarring nail plate biopsy, where, I mean, it's just a matter of time that the nail grows back and there is no potential of scarring, to the potentially scarring proximal nail matrix biopsy. And in all these sites, you have to be careful about how you are orienting your incisions or how you are reaching your area of interest. That is, whether you avulse the nail plate or you don't, or whether you take it out with the help of a punch or as a fusiform excision. All these things you have to need to keep in mind. The tangential biopsy is something which is preferably done in the matrix, especially when dealing with longitudinal melanonychia, where your index of suspicion for a malignant melanoma is low. Other than that, you have the technique of a nail fold biopsy, where it is again a crescentic excision, but as the nail fold turns, so the incision should also turn, so that you are able to recreate a anatomically normal nail fold, because after taking biopsy, you have to close it also. Another technique which is very less commonly used now, I started off using this, 15 years back, but I don't do it. I have not done it for the past 10 years or so. It's a longitudinal nail biopsy, which gives you a wealth of information, but at the same time, you have to be prepared for a shortening of the nail plate. Coming to the easiest technique of nail plate biopsy, Dr. Shikha has shown us how to take it with a punch. The indications are suspected onychomycosis, suspected warts or nail psoriasis. Easiest and least scarring technique, but gives limited histopathological data because you're not seeing the changes which are happening at the interface. Whenever we take off the nail plate, it is the tendency of the nail bed epithelium to come off with the nail plate because it is more tightly adherent to the nail plate than to the nail bed dermis. Again, in nail, the dermoepidermal junction is the weakest link in the whole scenario. So because of that, when you're taking a plate biopsy, you're going to get the nail bed epithelium also, most of it. But if you need to understand the changes at the interface, like in lichen planus or other such conditions, then you should be doing nail plate biopsy. If your intended change, like mycomycosis, lies only in the nail plate, you might as well just do a nail plate biopsy. So one way was doing it with a punch, and that is recommended when the defect is lying more proximally in the nail plate. Whereas if the defect is very distal, like in this suspected nail wart, you can easily take it with a splitter. Here, you need not even anesthetize the digit because this is actually like cutting your nails with a heavy duty nail cutter. More, you can say it like that. But any specimen more than 3 mm is likely to stick in the block, and you can get a wealth of histopathological information from that. So nail plate biopsy is indicated whether the nail dystrophy originates from a fungal infection, the origin of nail plate pigmentation, whether it is melanin or hemosiderin, because it's a common source of confusion when a patient presents with a sudden onset black spot. So you're not sure whether this is a subungual hematoma, or you should be worried about melanin or melanoma. So a nail plate biopsy can help in this scenario. Our diagnostic information in nail psoriasis, because infiltration with neutrophils into the nail plate is the single major criterion for diagnosis of nail psoriasis, and that much information can be derived from a nail plate biopsy. Occasional papers have also shown it to be useful in systemic disease. For example, in gout, you can actually visualize the uric acid crystals present within the nail plate. Coming to the nail bed biopsy, again, the punch part is discussed. So I'll be talking about the elliptical incision, or excisional biopsy rather, which should be longitudinally oriented in the nail bed, as has already been discussed. When we come to the longitudinal excision, we do it with nail avulsion because we need to be precise. But nail avulsion under all circumstances should be partial as far as possible. So you should be able to localize your area of interest and avulse the nail plate only in that area, because it has a better post-surgical outcome. Suturing of the defect may be required. Again, this was a question asked. The suturing of defect is unnecessary if you have created a defect less than 3 mm in size. And when you're suturing the defect, then replacement of the nail plate is something which is more problematic for the patient. So it leads to more symptoms in the post-op period. So if you are taking the decision to suture, then you may forego the decision of nail plate repositioning. So an excisional biopsy, like in this case of a suspected glomus tumor, blue thing, if I take it out with a punch, I'm likely to leave behind areas of the glomus tumor. I have to take it out in toto so that the patient's symptoms are relieved. Even a small bit left is pain for the patient, which is, as good as a biopsy not done. So removing the nail plate, excising the lesion, and suturing the defect. So for this, you do a partial excision of the nail, partial avulsion of the nail, because you are fairly certain of your localization based on your patient's history, pinpoint tenderness, as well as MRI localization. Then the lesion which is exposed, the lesion which is seen is to be exposed from its entirety with the help of blunt dissection, which I am doing with the help of a jeweler's forceps. As this part will take you a few minutes. Slowly the lesion will become more prominent and start popping out. All this is done with the help of a blunt dissection only with the jeweler's forceps, which is again non-TUS, as Dr. Shikha had said. Once it has been delineated, you can safely remove it. No use of scissors required. And the linear defect which is created, it is clearly more than 3 mm. It is 5 to 6 mm. So I'm having to undermine the edges of this linear defect so that I can approximate both the edges, both the sides of the nail fold. of the nail bed. The nail bed, you need to understand, has longitudinal ridges. So it has a longitudinal anatomy and it needs to be sutured longitudinally, just like I'm doing here, the suturing of the nail bed defect. This can be followed by nail plate repositioning, but you might want to cut off this part of the nail plate if you are not using absorbable sutures in the nail bed. So all these decisions have to be taken while you are doing the procedure. Then coming to the next, nail fold biopsy. This is reserved for parametrial dermatosis or tumors which arise in the nail fold, commonest of these being the mucoid cyst. It can again be done by all these techniques which are listed here. But the essential part in all of them is the use of the spatula underneath the nail fold, so that you are restricting your excision to the nail fold and not damaging the underlying structures, which happens to be the matrix in the case of proximal nail fold. So this schematic shows this really well. This is the proximal nail fold. You insert your spatula, the green colored thing, and then you take a crescentic excision of the nail fold or the nail fold biopsy, whichever you have planned. This is a mucoid cyst, an organized cyst, which was not regressing with the help of triamcinolone. Please note the orientation of the primary incision here, which helps you expose the cyst and remove it in toto. Some amount of redundant skin was then clipped and a primary closure was done, and this is the result after 2 weeks. So if your incision is oriented according to the direction of the nail fold turns from the proximal to the lateral nail fold. So your incision should also turn slightly so that a primary closure along RSTL is achieved. Next, coming to nail matrix biopsy, which happens to be something which everyone is scared of, and rightly so, because you should not be actually tampering with the nail matrix straight away. So you do a matrix biopsy when no other biopsy is likely to be useful, and we have discussed the site selection. So it is necessary for exploring the matrix origin of longitudinal pigmented bands or benign lesions of the nail matrix like glomus, which most commonly arises in the matrix only, suspected malignancy, or for acquired nail plate defects, because the defects which are seen in the nail plate arise from a pathology lying in the nail matrix. Biopsying the defect in the nail plate is not likely to give you any useful information. The techniques here are again elliptical excision, but it has to be horizontally oriented because that is the orientation of the matrix. A punch excision, please try to keep it less than 3 mm as outlined by Dr. Shikha, or a tangential or a shave excision, which is a very superficial excision, so that even if you're removing larger parts of the matrix, much more than 3 mm, the residual risk of scarring is low because of the presence of dermal rest of stem cells. General principle, you should try and biopsy the distal matrix rather than the proximal matrix whenever possible. And the lunar margin needs to be preserved. So like this is a longitudinal pigmented band where we are interested in what is giving rise to this band. So we explore this first by retracting the proximal nail fold, giving two release incisions along the junction of the proximal and the lateral nail folds. And after that, we do a tangential excision. So you can see post-tangential excision, you can hardly see the defect. Just the fact is the specimen taken out is so thin that during histopathological processing, it may turn over itself. So we need to find a way to embed it properly. Indications for matrix biopsy I've just discussed. The techniques also I have just told, and the general principles just for revision's sake, because this is an area which you need to be careful for. Biopsy distal matrix rather than proximal matrix whenever possible, and preserve the lunar margin whenever possible, because once you cross it, then the risk of scarring and a residual defect in the nail plate is high. This is a distal nail matrix biopsy, which requires a limited exposure of the matrix. So here, the release, incision, business, and retraction of the proximal nail plate may not be required. And only with the help of a skin retractor or hook, you can reach the distal lunar part of it.
But this applies only for the larger nails, let's say the great toenail or maybe the thumbnail. And the post-procedure PNF, which is allowed to fall back by removing the skin hook, it heals really well. So as you can see, cleaning and draping this nail where you have a linear defect, which I am going to move to the proximal origin of that nail, linear defect, to visualize what exactly is wrong in that area. This is the proximal digital or the ring block being administered, followed by exsanguination and tourniquet of the digit, which is an absolute must before any nail surgery, including nail biopsy. Then after that, this is me defining the site of the biopsy. So I'm outlining the lunular margin for you, and I have to remain proximal to that. So I will use the spatula to separate the proximal nail fold from the dorsal part of the nail plate surface. This is just releasing in this area to minimize any unnecessary trauma to the rest of the nail fold or the nail plate. Then with the help of skin hook, I am pulling back the released nail fold. And with the help of the chosen punch, I am taking a punch biopsy proximal to the lunular margin. This will drive a cylinder, which needs to be taken out with the help of fine forceps, which are non-toothed, and I use gastrovisual scissors for this purpose. So this biopsy cylinder comes out, which can be then sent for histopathology. Post-operatively, first release the tourniquet, secure hemostasis, clean the area, and simultaneously give an absorbent dressing underneath over the operated area, followed by a dressing which is absorbent enough, as well as of the discharge coming from inside, as well as the trauma from outside. A proximal nail matrix biopsy requires more proximal exposure of the PNF. So you give lateral release incisions, which could be given unilaterally or bilaterally, depending on which area you want exposed. So if it is somewhere in the middle, you'll have to release from both the sides. The released nail fold, proximal nail fold, is then held back with the help of stay sutures, and it is allowed to fall back post-operatively. So this is the initial step of separating the proximal nail fold. Here you see I'm using the nail spatula and separating the whole proximal nail fold from the dorsal surface of the nail plate, because my the longitudinal pigmented band is placed very centrally. I'll be giving release incisions on both the sides. Please see the insertion of the spatula underneath the proximal nail fold first, and then using the blade, so that I'm cutting only the nail folds and my blade doesn't go deeper than that. Then I will use stay sutures so that the released proximal nail fold, which has been released from both the lateral nail folds, can be retracted and held back with the help of a artery forceps. And having traveled back enough towards the origin of the longitudinal pigmented band, I'll take a punch biopsy specimen from there. Here, nail matrix has very minimal dermal tissue. So you strike the periosteum very fast and you have to take out the whole specimen in toto. And after that, you remove the stay sutures and allow the proximal nail fold to fall back. It is sutured in place. So just to summarize with the help of stills, this is the procedure done. This is immediate post-op. And this is somewhere around 2 months later when the normal nail plate is growing back. Lateral longitudinal nail biopsy is the last biopsy that I'm going to talk about, because we generally don't need it. It is useful only for larger lesions which are placed asymmetrically and samples the entire nail unit. But it's a potentially scarring procedure because you are compromising the nail matrix, as you can see from this procedure. It requires suturing of the nail plate with the lateral nail fold. So even the risk of implantation cysts had been mentioned in earlier literature. So here your direction, while you're suturing, your direction of entering is from the lateral nail fold to the nail plate. You do not come from the nail plate to the nail fold, because then you have higher chances of embedding keratin into the nail fold. Post-operative care has been discussed by Dr. Vineet in great detail.
One thing which I want to specify, especially when you are sending your specimens to the pathologist, clinico-pathologic correlation is a must for interpreting nail biopsies nicely. And because this is essentially different from skin, your pathologist needs to know where the biopsy specimen came from and where the defect was. And it helps them even orient while sectioning and for reporting normal versus abnormal features, as Dr. Sonal is going to discuss. So this is the practice that we do at UCMS. We draw a nail diagram and we pinpoint exactly, like this is a bed biopsy and this is a matrix biopsy which has been taken. In literature, you have these suggestions of incorporating the nail biopsy in a pre-drawn diagram and using an indelible ink to mark the proximal end, because this way, if it is fixed in formalin, then it is easier for the pathologist to process it further. We do not have all these paraphernalia available with us easily, but we try our best to put it in a diagram and then discuss with our pathologist. So clinico-pathological communication is a must for getting a good outcome after your nail biopsies. You also need to, yeah. I'm just closing. Side effects of the nail biopsy need to be explained to your patient. As I said, you need to take an informed written consent because the patient is likely to have some functional handicap. These are the complications. And the last three are practically negligible if you are careful about doing your nail matrix biopsy very properly. So to summarize why you should do it, because it's not that scarring a procedure as it is made out to be, and useful in isolated nail manifestations. It gives you a definitive rather than a conjectural approach towards planning treatment for your condition. But you should not do it when a skin biopsy can be easily taken or the diagnosis is confirmed on direct microscopy or culture and is in sync with what you were clinically thinking. And you should be careful about patients who have any compromise with respect to their peripheral vascular supply. To conclude, nail biopsy is not routinely indicated, but when indicated, it is often the only option that you are left with. So it pays to be conversant with the procedure as and when it is required. And dermatopathology backup is very important in getting a good output out of your properly done nail biopsy. I thank you all for your kind attention.
Thank you so much, ma'am. There's just one question. Can we use a wing block instead of proximal block while doing a matrix biopsy?
We can use a wing block. It is much, faster onset and uses a smaller amount of the anesthetic solution. But then you have to give it on both the sides of the nail at the junction of lateral and proximal nail fold. And I find it slightly more painful for the patient to take anesthetic in the distal part of the nail rather than in the proximal part of the digit. But it can be used, yes.
Thank you, ma'am. Thank you very much.
Isn't it wean off also very early as compared to the proximal digital block? So for adding on to, if the proximal digital block is fading on, the effect you can give wing block. That's my suggestion.
Thank you, ma'am. Thank you for that input. Thank you for that input. So thank you very much, Chander ma'am. Very, very nice talk. I think we could understand very well with the help of the pictures. So moving on, we are very pleased to have Dr. Sonal Sharma with us. She is a Director Professor Pathology at University College of Medical Sciences. And ma'am will be talking about nail biopsy processing and histopathology. So we'll have a pathologist view now. Over to you, ma'am.
Thank you, Khushbu. I hope I'm audible. And
yes.
My screen is visible?
Yes, it is.
Okay. So now we are going to continue with the nail biopsy procedure, but we are going to look at it from the pathologist aspect. Okay. So we are going to see how the things look under the microscope. So before I go to the microscopy, let me at least talk a little bit about the anatomy of the nail apparatus. So as you can see, this is better appreciated in a cartoon diagrams. I will show you the histopathology also. Okay, so let's start with this. So we have, the continuity of the skin of this is the skin, and this epidermis of the skin only folds and makes the proximal matrix, it's in continuity. This is a proximal nail fold, and the skin on the top of this is similar to the normal skin, except it is devoid of any appendages. And this folds and forms a proximal nail fold. And this, after the proximal nail fold, the matrix, this continues as the nail bed. And this matrix is the one which largely produces the nail plate. And here we have the hyponychium or the distal nail fold. And underneath, of course, we have the bone and everything else. So the nail plate, how is it produced? It is produced from top down. What I'm trying to say is the top layers of the nail plate are produced by the first aspect of the matrix. Means the most proximal matrix produces the topmost layer. So looking at the pathology in the nail plate, you can predict where the disease is starting from. So if it is characterized by a lot of superficial pits and superficial lesions, that means the more proximal aspect of the matrix is involved. All right. So it is important to know this. And as we go down, the lower layers, middle and the later layers. And earlier it was thought that the nail bed does not contribute at all to nail plate production, but now it has been seen little bit of maintenance layers at least are added even by the normal nail bed also. But majorly the entire production happens only in the matrix region. The proximal nail fold is defined as the proximal border of the nail plate. Okay, so after the border, we have the proximal nail fold. So it extends from the skin above proximal most aspect of the nail matrix to the cuticle. So this is the area which is called as proximal nail fold, the entire thing. Okay. So amongst this, we have the proximal matrix and we have the distal matrix. So proximal matrix extends from the blind pocket to the cuticle area. So the cuticle, it is the one which is, basically a hyperkeratotic area which protects, it kind of binds the nail fold to the nail plate. So from here to here, we have the proximal matrix. And this produces the most of the nail plate, 50%. And the area is 50%, but it produces 80% of the nail plate. The distal matrix, on the other hand, extends from cuticle to the proximal nail bed. Okay, only a little bit part. And it is visible as the lunula through the nail plate and produces the lower part of the nail plate. The cuticle, I've already told you, it's also called as eponychium. It's a layer of epidermis with hyperkeratosis, and it protects the nail matrix from pathogens, allergens, irritants. Okay, so it is important. So usually, if you have ever get your manicure, pedicures done, this cuticle is very, they are very fond of removing this. So it should not be removed because it acts as a protectant and protects your nails. Coming to the nail bed. So this is the bed. This is the epidermis by which the plate is stuck onto the digit. Okay, and it represents a majority of structures visible through the pinkness which you see as the nail plate is all nail bed. And I've told you it nicely adheres it to the digit. And there are longitudinal ridges and which helps in better adherence of the nail to the bed. It was earlier thought that there is no role in nail plate production of this nail bed, but now it has been seen it does have some role to play. So when you remove the nail completely, you can appreciate these ridges, and they are seen in the nail plate, underside of the nail plate also. So these grooves and ridges are the ones which help in binding of the nail plate. So the plate itself consists of a keratinized structure and is produced throughout the life. And we all know in fingers, they grow around 3 millimeter per month and toes around 1 millimeter. This nail plate growth is influenced by multiple internal and external factors. Coming to hyponychium, which is the distal border of the nail apparatus. It extends from nail bed to the distal groove. So there is a groove here, and it's again composed of hyperkeratinized epithelium, and again acts just like cuticle. It's an kind of protects the nail plate from various nail bed from various irritants and pathogens. So this is just to show you histologically the entire proximal, this is the skin over the top of your finger and it is forming the proximal nail fold. This is the cuticle and this is the nail matrix, the proximal nail fold, entire thing. So the top is formed by skin, but there are no appendages in this area. And this skin epidermis only becomes in continuity and forms the matrix epidermis. So compared to the normal epidermis of the nail bed, the matrix is much more thicker in length, more acanthotic you can say, and it is much more active because the more the proximal, it is more producing most of the nail plate. And this is the nail plate. On histology, the nail plate looks like having a pale uniform appearance with hardly any nuclei seen on low power. But on high power, you can see. And this is what the nail bed looks like. No appendages, only a lot of blood vessels and nerves. This is a higher power view to show you what a nail plate looks like and the nail bed. And as you can see, there can be some amount of nuclei can be retained, which are usually visible on higher powers. And if you look at the epithelium, it is formed in these rete are oblique. They are not vertical like we see normally in skin epidermis. Because, you know, in skin, the epidermis grows vertically up. Whereas nail, the growth is oblique. Otherwise, you will have nails growing vertically up, which is not the scenario. This is another histological image to show you the proximal nail fold, how it's going in and forming the nail plate, and to show the difference between the epidermis in the matrix and the nail bed. So this is a higher part to show the nail matrix. And this again has keratogenous and non-keratogenous zones. So we have the nucleated areas. Then we have areas with retained nuclei, but they otherwise are keratinized. And then we have more keratinized without nuclei area. It's important to know all this. And as you can see, this is the top layer of the matrix area. This is not the matrix epithelium. This is the continuation of the skin. And as you can see, there is a granular layer here. Whereas the one in the matrix doesn't have any granular layer. Even the nail bed epithelium also does not have any granular layer. This is important because in most of the inflammatory diseases, an abnormal granular layer appears, and that helps us in making the diagnosis and differential diagnosis. So this is just to show the difference between the matrix epithelium and the nail bed. So the nail bed epithelium is not much thick like matrix. Also, it has the rete ridges are not very well developed in a nail bed epithelium, as you can see here. This is the nail bed. So it's lined by the epithelium, and this is the dermis of the nail bed. So you don't have any appendages, lot of vessels, and they can actually show you glomus bodies also around these vessels, and lot of nerves are there. And sometimes, like we have been talking all about the biopsy precautions and everything, a little aggressive biopsy and you can get bits of bone also underneath this, because this is directly resting on the periosteum. This is to show you the distal nail fold. So this is how the nail plate is ending. So this is called as hyponychia, and this is again a groove which is filled with keratin, and this keratin protects. And after this is the pulp of the finger, and you can get appendages here, but not here. A word about melanocytes, because a lot of pigmented lesions are also seen. So you have to know how much melanocytes are there in a normal nail. The matrix and a little bit in the nail bed, there are some melanocytes even in physiological conditions. So just to show the difference between epidermal melanocytes and the matrix and nail bed melanocytes. So matrix has much compared to the epidermis. The number in matrix is very less, and nail bed usually you hardly ever see any melanocytes, and the density is very less. And the distribution of the melanocytes can be there in the upper layers also in the nail matrix, but like in skin, we all know they are seen only in the basal layer. What you have to remember is, even if you find the melanocytes in the proximal matrix and also in the bed, they are dormant. The only place where melanocytes are active is only in the distal matrix. So this is important for you, especially if you're trying to take a biopsy for a pigmented lesion. So you know this is the area you must biopsy if you're suspecting a pigmented lesion, because this is where the dormant, the active melanocytes reside, and this is the area where the melanocytic lesions arise. And also another thing we have to remember as pathologists is we very frequently we use S100 staining to highlight melanocytes in skin. The melanocytes in the nail do not stain for S100. So you can frequently use Mason Fontana, etc. to stain the melanocytes. So we have talked a lot about nail biopsy already. So you know it can be diagnostic or therapeutic. And depending on the pathology, you might do a plate biopsy, nail bed, or nail matrix. This has already been discussed widely. So a word about processing. So once a biopsy has been done and we have received the biopsy, so what is to be done by the pathologist? So the thing we have to remember is that the nail is very hard. Why is it hard? It is because there's so much keratin lying in the nail. Now the nail plate is heavily keratinized, and this keratin also compared, though it is keratin is present in our skin and hair also, but why is this so hard? Because it has heavy amount of sulfur, and there are these disulfide bonds which are very strong bonds present in there. So the rest of the things are also there, but sometimes some pathologists, if they are not aware, they might try to soften the nail similar to what they're used to softening, which is bone. So they try to use the decalcification procedures on the nail also. So this we must remember that the nail requires a different steps of softening. So what you're trying to do is you have to soften the keratin, and that is done by various softening agents and not decalcification, because actually this calcium is very little in amount. So the most of the decalcification agents act on the principle of chelation, which is removal of calcium. So there's hardly any calcium. So if you keep adding chelating agents, it will have no effect on the nails. So if you don't soften the nail, and if you try to cut the nail, because it's so hard, because even if you have a very good blade, it will shatter. The nail is going to shatter up into pieces. As a result, you won't be able to maintain the orientation of the biopsy at all. So softening the nail will improve the ease of cutting and the quality of section. So this has to be mastered by the pathologist in order to get a decent histopathology, because all this exercise which you're doing in biopsy, so much effort is taken. It's such a painful procedure, but if you don't do softening well, everything goes futile. And there's little published work on the softening agents. Another thing we must realize is when we receive the biopsy, like Dr. Chander has also demonstrated, you must make a diagram and send the biopsy labeled properly. And actually, when you do the biopsy, you will realize that most of the time the plate and the bed are separated. So do not worry, it happens, we agree. And you can send them either in one tube, or better label it and put it in different vials, because sometimes if there are two bits, one might get stuck in here and there because they are small biopsies. So it's better to put them into different tubes and send them and put the tag. This is a plate and this is the deeper bed biopsy. So when we receive, and also another thing is when if you have this double biopsy, I will not soften the bed biopsy. I will only soften the plate. So it is good to label them as separately and make a diagram and show exactly from where you have taken the biopsy, because I've told you the morphology is different for matrix and proximal and distal, also in the bed, or if it's just nail fold, then it's almost like skin only. So we must have a good description and diagram. So how do you do? So you must also, while making a diagram and everything, give the time of the biopsy when you've taken the biopsy and put it in formalin. Why? Because when we receive the biopsy, we have to time it accordingly, because it requires minimum 24-hour fixation in formalin before we begin the softening steps. So if you've taken the biopsy today and I'm receiving it tomorrow, then it's okay. Then I'll straight away start with the softening step. However, if you've taken it today and I've got it today only, then I'll leave it overnight and start the softening next day. For the softening, we have actually done work on various softening agents, and we tried to use agents like thioglycolate based, the depilatory creams which you use for hair removal. We have used softening agents which have been described, you know, the softeners we use for clothes. So those also we have tried. They do work, but the densities, because they have very viscous density, so they do not penetrate very well. So for working routinely, I have found 10% KOH works best for the routine nail biopsy. So we leave it in 10%. You can actually even go ahead and do 30%, but that will be a little daring, because if your timing gets a little off, if you forget, your nail might completely disappear, like, you know, for the KOH we do in for fungal microscopy. So don't use concentrated KOH, just use 10% is enough. Use it for few hours. We can leave it, but never ever leave it overnight. Reason being, it might completely dissolve. So if you find that you've processed it for a few hours, but it's still, you never check it by putting pins inside. You just feel it by bending the nails a little bit. If you feel that it is still not softened enough, do not worry. Take it out of the KOH, leave it in water overnight, and again start the next day for KOH. So it's more than enough usually, but do not please leave it overnight in KOH. And then after that, again, you rinse it in water and then put it in formalin for another 24 hours. It will fix properly, and then it is processed just like any routine tissue is processed. So histopathologically, basically what we get the biopsies are majorly inflammatory diseases, like 3 diseases we get the common histopathology indications, like psoriasis, lichen planus, onychomycosis. These are the 3 most common diseases which will be dealt with our colleagues in the upcoming talks. Other diseases like 20-nail dystrophy, lichen striatus also there. Melanonychia offer frequently any pigmented lesion. Biopsy is done. Then various tumors, epithelial, mesenchymal, like onychometricoma, glomas, these are commonly biopsied, and other systemic disease also require. So these all the histopathology aspects we will be discussing soon in the coming talks. So thank you so much.
Thank you so much, ma'am. That was really elaborate and helped us understand the pathologist view, and some tips which were really helpful for our day-to-day practice. Thank you very much, ma'am. So now we move on to the nail biopsy in specific disorders. So first we have nail biopsy in psoriasis, which is by Dr. Subuhi Kaul. She was a UCMS dermatology resident and is currently pursuing her double residency in Chicago. So Dr. Subuhi, over to you.
Hi, thank you for that introduction. Good afternoon, everybody. So my topic for today is, let me just start the slides, clinical histological correlation in nail psoriasis. And this was done with the guidance of Dr. Archana Singal, and my co-guides were Dr. Chander Grover and Dr. Sonal Sharma. This was done at UCMS while I was doing my residency there. So coming to the introduction, why did we do this study? It's because disorder, and around 80 to 90% of patients with psoriasis have nail involvement. If this nail involvement is isolated, which is seen in about 5 to 10% of the patients, this can present a diagnostic challenge, especially if there's changes like onycholysis or subungual hyperkeratosis, which are very common with onychomycosis as well. So a little bit more background, the changes seen with nail psoriasis can differ with the part of the nail involved, which have already been explained by Dr. Sonal Sharma very well.
Can you share your slides? You can't see your slides.
I'm sorry, 1 second. Is it visible now?
Yes.
Okay, I'm sorry about that. So like I was saying, that the changes seen in nail psoriasis depend on the part of the nail involved. This could be pitting, Bowes lines, leukonychia, red spots seen with nail matrix changes, as well as crumbling nail plate, which is a very dramatic presentation of nail psoriasis. Nail bed changes include onycholysis, oil spot or salmon patches, subungual hyperkeratosis, splinter hemorrhages, discoloration, nail fold changes, which can be seen usually in association with the other changes are paronychia, acropustulosis, and pterygium formation. What we aimed to do with the study was to assess and clinically correlate the histological features with the clinical features of nail psoriasis. This was done between December 2013 and March 2015. We included 60 patients with clinically suspected nail psoriasis at UCMS. And our inclusion criteria was any patient with two or more nails involved with signs and signs of either nail matrix, nail bed, or paronychial changes. Nail fold changes. This could be pitting, oil spot, onycholysis, etc. We excluded patients who were below 18, were pregnant or lactating, had received any antifungal treatment in the past 3 months, or this was for systemic treatment, and any topical antifungal treatment in the past 1 month. We also included any patients who could not get a biopsy for any reason, for example, peripheral vascular disease, diabetics, connective tissue disease, anyone with anticoagulant drug intake or allergy to the anesthetic agent. We got ethical committee approval and consent from all patients and examined all nails under very good light. We did a nail plate plus bed biopsy with a punch, which was a 3 millimeter punch. And in a lot of cases, this was separate, the plate, and especially if the plate was onycholyzed, it was separate from the nail bed. It's mentioned by Dr. Sharma already. The biopsies were subjected to H&E stain, and the histopathological criteria we used for diagnosis was the one proposed by Hanno et al. The major criteria was presence of neutrophils in the nail bed epithelium and in the adherent parakeratotic fragments of the nail plate. Minor criteria included the presence of hyperkeratosis and parakeratosis, serum-like proteinaceous exudates within the Horny layer, focal changes in the granular layer, which is different from psoriasis on the skin. Here you see hypergranulosis. Psoriasiform hyperplasia of the nail bed epithelium with dilated subepithelial blood vessels. We calculated the percentage positivity of each histological feature and clinically correlated with the nail findings we saw. So what did we see clinically? We saw that distal onycholysis was the most common finding in over almost 95% of the patients. Subungual hyperkeratosis was seen in about 80% of the patients. This was followed by pitting, cuticle changes, leukonychia, discoloration, salmon patches or all drop sign, longitudinal melanonychia, Bowes lines, trichonychia. The most uncommon changes was crumbling and red spots in lunula. These are a few cases that demonstrated pitting really well on the top. On the bottom, we have onycholysis along with subungual hyperkeratosis. And then on my right-hand side, we have distal onycholysis with the characteristic red border. It's seen especially well in the thumb, in the 4th and 5th digit, and we can also see splinter hemorrhages in the middle finger. There's another picture demonstrating onycholysis with a red border on the left-hand side and crumbling nail plate, where it's almost the entire nail apparatus is almost entirely destroyed. And we can see that the proximal nail fold shows some paronychia. Now, what we found was that most patients with onycholysis was the most common feature in patients with fingernail involvement. This was slightly less common in those who had toenail involvement. And subungual hyperkeratosis as well as brownish discoloration was much more common in those with toenail involvement than with fingernail involvement. Pitting likewise was much more common in patients with in fingernails than in toenails. And crumbling again was more common in toenails. So coming to our histopathology findings, about 2/3 of our biopsies were taken from fingernails and 1/3 from toenails. And what we biopsied in most cases was subungual hyperkeratosis. This was almost 75% of the cases. In 3 of these cases, the subungual hyperkeratosis part had overlying pitting on the nail plate biopsied. Onycholysis was biopsied in 20% of the cases, and a crumbling or completely destroyed nail plate was biopsied in 5%. Now, this is just a pictorial representation of what I summarized already. And why this is important is because when we try to correlate the clinical features with the histopathological features, we actually excluded the ones in gray and dark blue because we wanted to take a single clinical feature and correlate it with what we saw in histopathology. So for crumbling nail plate, there was nothing else on the nail plate because everything was destroyed. For onycholysis, we saw pitting and splinter hemorrhages, and we excluded those 6 cases. So we only took 6 cases of onycholysis to correlate the histopathology. So what did we see on histopathology? The most common feature we saw was hyperkeratosis and parakeratosis, almost in 78% of the cases. This was followed by psoriasiform hyperplasia with dilated capillaries in 65% of the cases, neutrophilic infiltration in 63% cases, and hypergranulosis and serum exudates were less common. These are just representative pictures. The first one shows on my left, hyperkeratosis and parakeratosis seen in the nail bed. This was on a high power field. And on my right, we have a thickened onycholytic plate. We can see how it's fragmented. The whole nail plate is thickened and fragmented. And we can see the hypergranulotic layer followed by acanthosis in the nail bed. There's another picture showing neutrophilic infiltration forming an abscess in the nail plate. And on the right, we have a higher power image showing squirting neutrophils. A picture showing psoriasiform hyperplasia, and the same one has been magnified to show the dilated capillaries. This is a picture showing serum exudates, which was an uncommon finding. So just to summarize, the most common features we saw were hyperkeratosis and parakeratosis coexisting in about 78% of the cases, followed by psoriasiform hyperplasia with dilated capillaries in 65% of the cases. And the most uncommon were, the less common were serum exudates, melanin deposition, acanthosis, and hemorrhages. Now, this is the part where we try to correlate the clinical features seen with the histopathology that we found. When we try to correlate the subungual keratosis that we biopsied, we found that the most common pathological feature was hyperkeratosis and parakeratosis in 78% of the cases, followed by neutrophilic infiltration and psoriasiform hyperplasia. In these cases, the other features seen were serum exudates and hypergranulosis, but they were less common. For cases with onycholysis that was biopsied and had nothing else on the nail plate, we found, again, hyperkeratosis and parakeratosis and psoriasiform hyperplasia with dilated capillaries in 66% of the cases. And a little bit less common was neutrophilic infiltration and hypergranulosis serum exudates in half of the cases. Coming to crumbling nail plate, we found that hyperkeratosis and parakeratosis, hypergranulosis, and neutrophilic infiltration was seen in all cases. Now, if you remember, crumbling nail plate is due to involvement of the nail matrix. And it just shows that it's a very severe kind of reaction, and all of the changes were seen in this cases, including serum exudates and psoriasiform hyperplasia, which was seen in 66% of the cases. Especially, to note is that serum exudates were more common in these 3 cases than in the other cases of onycholysis and subungual hyperkeratosis. This is, again, a pictorial representation of what we found on biopsies of the crumbled nail plate. This is our table summarizing all of the findings we found. So in patients with subungual hyperkeratosis, clinically, you were expected, or we found that hyperkeratosis was the most common along with parakeratosis. And the second more common were psoriasiform hyperplasia with dilated capillaries and neutrophilic infiltration, followed by other changes. In cases of onycholysis, again, we find hyperkeratosis and psoriasiform hyperplasia with dilated capillaries, followed by other changes. Whereas in crumbling nail plate, we'll find very commonly neutrophilic infiltration, hyperkeratosis and parakeratosis, hypergranulosis, and also serum exudates in psoriasiform hyperplasia are common. So a whole variety of changes in crumbling nail plate. All of these findings were very similar to the previous study done by Grover et al., who also reported hyperkeratosis and parakeratosis to be the most common finding, and Hanno et al., who found similarly hyperkeratosis and focal parakeratosis to be present in all of their cases, along with 100% of their cases having neutrophilic infiltration and dilated dermal capillaries. So what we wanted to determine with this study was if we get a crumbled nail plate, for example, how do we differentiate between onychomycosis and nail psoriasis? What we can see with the crumbled nail plate is that we can find not only hyperkeratosis and parakeratosis with neutrophilic infiltration, but we can also see serum exudates in these cases. Of course, to determine specificity and sensitivity of each histopathological feature of nail psoriasis, we would need a larger sample size. We only had about 3 cases with isolated nail crumbled nail plate that we could biopsy, and about 6 cases with isolated onycholysis. So we would need larger studies. These were the references I used. Thank you for your patient listening.
Thank you so much, Dr. Subuli. It was a very nice study, and thank you so much for your talk. And I know we are in different time zones. You managed. Thank you so much. So moving on to our next speaker. So we have nail biopsy in lichen planus, and I have Dr. Gitali Kharkoria for that. Dr. Gitali is a senior resident at Department of Dermatology, AIMS. And over to you, Dr. Gitali.
Thank you, ma'am. Good afternoon, everyone. I'd like to thank NSI. Just a second. Is my screen visible?
Yeah, it's visible.
Okay. Yeah, I'd like to thank NSI, Dr. Sushil Tahilaini sir, Dr. Chander Grover ma'am, and Dr. Archana ma'am for giving me this opportunity today. I'll be discussing the nail biopsy in nail lichen planus. Nail lichen planus is not very common, but sometimes we do get cases of nail involvement in lichen planus where we are faced with a diagnostic difficulty, because nail lichen planus can mimic many other inflammatory and infectious nail disorders. However, in the presence of classical findings like a pterygium or an anonychia, we can diagnose nail LP with surety on clinical examination itself. However, in the absence of these clinical classical findings, we tend to look for other evidence of lichen planus at other mucocutaneous sites, like most commonly oral mucosa has been described in association with nail lichen planus. Apart from that, we also have onychoscopy nowadays, which helps us support our clinical diagnosis. And finally, we have histopathology. And histopathology remains the gold standard for diagnosis of nail lichen planus, especially in cases where we have isolated involvement of the nails. However, it has some limitations too. It's an invasive procedure and it has a low diagnostic yield of around 50%. Maybe these are some of the reasons that we don't have much studies on histopathology of nail lichen planus, because not everyone wants to do a nail biopsy and not all patients also want a nail biopsy to be done. So the types of nail biopsy has already been described in very much detail. But I'd like to say that in nail lichen planus, we usually take a nail punch biopsy, which can be either from the nail matrix, the nail bed, or the nail fold, depending on the site which is maximally involved in a patient. We also have excision biopsy, similar to punch biopsy, but instead of a punch, we use a scalpel. And the oldest technique is the longitudinal biopsy, where we can sample all units of the nail at one go, and therefore the diagnostic yield also increases. But it has the big limitations that there is a post-operative reduction in the nail width, and also there is malalignment of the nail after such a nail biopsy. So how to choose the site for nail biopsy? In lichen planus, when we have predominant nail matrix features in the form of like nail plate changes like onychorexis, onychocygia, or a thin nail plate, pitting, leukonychia, then we take a biopsy from the nail matrix, following all the precautions and all the like guidelines which have already been dealt. If the patient has nail bed features like onycholysis, subungual hyperkeratosis, nail bed erythema, and described finding of nail bed finding of linear nail bed dyschromia on onychoscopy, then we can take a nail bed biopsy. So in patients where a person has both nail matrix features like the nail plate changes and nail bed changes, we may prefer to take a nail bed biopsy because it has less morbidity, it's easier to do, and it's a shorter procedure also. In patients who have lesions on the nail fold, where we are not sure what the lesion can be, then we can biopsy from the nail fold rather than the nail matrix. The reported histopathological features of nail LP are depends on the site of involvement of lichen planus in the nail. It can be nail plate changes or nail matrix changes, like the epithelial changes, which can be either in the matrix or the bed, the nail bed dermis changes, and the hyponychial changes. Out of these, the sawtooth acanthosis, either of the nail matrix epithelium or the nail bed epithelium, and a lichenoid infiltrate abutting the nail bed, like abutting the epidermis in the nail bed. These are the specific findings of nail lichen planus. Based on all these reported findings, yeah, this is a picture. This is a histopathological picture. It's a nail bed biopsy where we can see a lot of subungual hyperkeratosis. We can see also the appearance of a granular layer in the nail bed, which is abnormal in nail bed normally. We can also see the sawtooth acanthosis. Here, the red arrow also shows a very focal lichenoid infiltrate. This is another nail bed biopsy where we can see a diffuse lichenoid infiltrate, and it's separating the nail epithelium from the nail bed. We can also see the appearance of the granular layer and also the fragments of the nail plate. These are additional features which occur secondary to lichenoid damage of the basement membrane in the form of these red arrows showing pigment incontinence and the black arrows showing the colloid bodies. Coming to the diagnostic criteria, a diagnostic criteria was laid down by Hanno et al. In 1986, where he included both the specific findings as part of major criteria and hypergranulosis and hyperkeratosis of the nail bed epithelium and increased eosinophilia of the nail bed keratinocytes as minor criteria. And for the diagnosis of nail LP, we need at least one of the major criteria with or without any of the minor criteria. So based on all these literature review, we went ahead in performing a histopathological study on nail lichen planus. I did this as part of my residency under the chief guidance of Dr. Chander Grover ma'am and co-guides Dr. S.N. Bhattacharya sir and Dr. Sonal Sharma ma'am in the Department of Dermatology, UCMS and GTB Hospital. We included 45 patients of clinically diagnosed nail lichen planus. We took one biopsy from the representative area of the nail in each patient. And finally, we could collect 25 bed biopsies and 20 matrix biopsies. Confounders like onychomycosis was excluded by doing a pass stain of the biopsy specimens. Coming to the results, we found that among the major criteria, The more common finding was a sawtooth acanthosis in 44% of the cases and a lichenoid band in a lesser number, around 24% of the cases. So adding up like the cumulative percentage of at least one of the major criteria was fulfilled in around 51% of our cases. Among the minor criteria, nail bed or the nail matrix hypergranulosis and hyperkeratosis was the most common in 51% of the cases. And overall also, this was the most common finding among all the features. And increased eosinophilia of the nail bed keratinocytes was seen only in one patient. Other findings like the fraying of the nail plate, which I will be discussing in my subsequent slide, and other non-specific findings like focal parakeratosis, pigment granules in the nail plate, spongiosis, serum crusts, increased basal layer melanin, colloid body, and pigment incontinence were found in different proportions. So based on Hanno's criteria, we could confirm the diagnosis in 51% of our cases. So this is the frayed nail plate I was talking about. Here we can see that the normal compact, this is the black arrow points towards the normal compact nail plate. Here we can see that the nail plate is separating into is separating into orthokeratotic individual onychocytes. Like we see in this picture where we see that this like old torn cloth, like where we can see the fibers, it resembles that. So we named it frayed nail plate, like this frayed jeans. This is another picture where we can see areas of frayed nail plate. In between, we can also see the compact nail plate. We can see the appearance of this granular layer here. We can also see this acanthosis and a lichenoid, almost a diffuse lichenoid infiltrate in the nail bed dermis. These are pictures of some of the non-specific findings. Here we can see that there is parakeratosis of the nail plate, which is more than what we see normally. And this is also one of the non-specific findings where we can see a lot of serum crusts within this parakeratotic nail plate. So our findings we published recently, and this is the reference. We should also remember that there are basic histopathological differences of nail LP compared to the cutaneous counterpart. Like we normally have differences of a normal nail histopathology also from a normal skin. In the nail, we see diffuse hypergranulosis as compared to the wedge-shaped hypergranulosis, which is described in in skin LP. And also the incidence of parakeratosis, spongiosis, and serum crust is more than what we see in a case of classic cutaneous LP. And we should also remember that a nail biopsy cannot differentiate between lichen planus and other lichenoid disorders like lichen striatus, graft versus host disease, and other lichenoid drug eruptions involving the nail. So to conclude, I'd like to say that in spite of all the limitations, histopathology it still remains the gold standard for diagnosis when we don't have any other option, especially in cases where there is only nail involvement without any mucocutaneous involvement. And whenever possible, we should try to take a nail bed biopsy, because nail bed is more commonly involved than what is actually reported in the literature. So we should go for a nail bed biopsy instead of a nail matrix biopsy if possible. And then the diagnostic criteria is very stringent in the sense that it includes 2 specific features, and so that's why it's not very sensitive. So probably we need to upgrade the diagnostic criteria. Maybe we can include some other features, or maybe a weightage-based criteria where we can give more points to the more specific findings, so that we can include so that we can diagnose more number of patients by histopathology. Thank you.
Thank you so much, Dr. Gitali. That was really elaborate. I don't have any questions. So moving forward. So next is nail biopsy in onychomycosis. And we have Dr. Mansa KN, who is Senior Resident and Assistant Professor at Kasturba Medical College, Manipal, who will be talking about nail biopsy in onychomycosis.
Thank you, ma'am. 1 second.
Yeah, it's visible.
Yeah. Sure. Okay. Thank you so much for giving me an opportunity to present myself today. And I'm going to talk about nail biopsy in onychomycosis. First, as we know, onychomycosis is fungal infection of nail unit, and there are various diagnostic modalities available like KOH, culture, and histopathology with PAS, and recently even onychoscopy. And there are less commonly employed ones like confocal microscopy or so. But why is nail biopsy essential? So one is we have to confirm the diagnosis because we are giving the antifungals for very long duration. So one is the health hazard and one more is the economy. And of course, we have to rule out the differential diagnosis. The most important ones being trauma, then psoriasis and lichen planus, like discussed earlier, and Machionechia congenita, contact dermatitis, nail bed tumors, or idiopathic onycholysis as well. And the most important one is secondary onychomycosis. So you will get a KH positivity, but it will not go off easily with treatment, or it will become recurrent. So in secondary onychomycosis, we have to go for a histology. So when we take a biopsy sample, what is unique for onychomycosis is if we have a tissue, we can do three things. That is, one is of course KOH, then we can do culture, and then one more thing is we can do H&E with PAS. So what to go for first? So ideally, we will always go for KOH because it has a high sensitivity, yes, but most importantly, it is easy to do and it has lesser time that is taken. But culture is very specific because you'll be able to identify organism, but you require a team as well. Histology is the maximum sensitivity, so it is the gold standard. And also, like I mentioned earlier, it can give a cause, that is especially in a secondary onychomycosis. But still, despite its highest sensitivity, it is not used as a screening method just because it is more time consuming and it is an invasive procedure. So we have a review of background literature on sensitivity of KOH, culture, and PAS. What would you go for? So it is seen in, like here, I have highlighted in yellow that most of the places we can see, like the earlier studies, they have shown that it is the PAS that is the highest sensitive. So like I mentioned, multiple textbooks always say that the gold standard is histopathology with PAS. So we also conducted a study. It was part of another larger study, and the objective being to compare the sensitivity of KOH, culture, and HPE with PAS in diagnosis of onychomycosis. So we conducted the study in UCMS under the guidance of Dr. Archana Singal, Dr. Deepika Pandi, Dr. Sonal Sharma, and Dr. Shukla Das ma'am. And details of the study is of the publications are there. And so we had 100 patients with clinical diagnosis, which is presumptive of onychomycosis, was recruited. And following this, when we were including the patients, we took only the cases which we thought was clinically onychomycosis 1, and the second being, we ruled out that it is not secondary onychomycosis. And then we did a detailed history and examination, and we did onychoscopy to identify the site from where we have to take the samples. So we did clipping or punch biopsy, and we sent it for KOH, culture, and histopathology. And if any of this was positive, we took it as a positive. So in that process, we had 88 positive cases and 12 were negative with all three, and that was taken as a control. And then we did the analysis. So when we are taking the sample, what we have to keep in mind? One is, because it is an infective condition, we have to decontaminate and always take the most proximal area. So decontamination can be easily done with just alcohol swabs. And also the site of the biopsy will depend on the clinical variant. And onychoscopy will always help to determine the site of biopsy. So for KOH and culture, we can just take nail scrapings and subungual debris, but sometimes it is not possible. Like in case of proximal subungual onychomycosis, sometimes we might have to take a part of the plate biopsy itself. And it can be in the form of a punch biopsy, like Shikha ma'am has described earlier. And for histology, we can use clipping or plate biopsy, especially in DLSO, SO, and endonyx, we'll have to do that. We can use a sharp nail clipper because many a times patient gets scared the moment we bring the nail splitter. So you can just use a sharp nail clipper. But most important thing is we have to soften the nail by keeping a saline soak swab for about 10 to 15 minutes. And if the nail is thicker, then of course we'll use a nail splitter. And local anesthesia may not be required in most of the cases in DLSO. But if you think that it is hurting for the patient, you can as well give it. But make sure that the adequate sample is taken, that is at least 3 millimeter of the tissue is required. And bed and matrix biopsy for TDO may be required, especially when the diagnosis is in doubt. And of course, here we'll have to give LA. But in our study, we did not have any patient with secondary onychomycosis because it was an exclusion criteria. So we did not perform any matrix biopsy. Coming to the site in detail. So this is a DLSO case. So what we would prefer is a nail plate biopsy. More proximal would be more ideal. But again, if you go more proximally, then you would have to give a LA. Here, like PSO. So we would be taking a plate biopsy here. Here, the clarity is not great, so onychoscopy will help. Just an example. So pathway for the nail sample. So if we take the nail samples next, we would have to put it in sterile covers and send for mycology, that is do either KOH and inoculation in SDA medium for the fungal element identification and for checking for the growth. The growth, at least for 4 weeks, we have to see before we declare that it is culture negative. Whereas in, say, in case of histology, we have to put it in 10% buffered formalin, like Sonal ma'am told earlier. And then we'll have to do sectioning and staining. And then identify the fungal elements and neutrophils, which I'll come in detail. So this is how the KOH looks, we know this. And then the culture morphology on the gross. And for finer details, we'll have to do on lactophenol cotton blue. And this is how the histology looks. So what we can see in this is the nail plates, which we can see very clearly, yes, and the PAS positive elements. So when it is in between the multiple layers of the nail plate, this is what is called as a sandwich sign, which is very characteristic for onychomycosis in nail plate. And one more thing, what we can see is the neutrophilic infiltrate. So this is a larger, better view of the neutrophilic infiltrate. And what happens is we'll end up getting a lot of this histological DD because of this. So even nail psoriasis has neutrophilic infiltrate. So the ideal way to identify would be a PAS. But again, it can still be a secondary onychomycosis. So we have to be thinking in that line as well. Then about the colonization of non-dermatophytic bacteria on the surface is very common to see. And in that case, we have to demonstrate that the fungi is penetrating the nail plate. And if there is candida, we should see for the budding. And if there is any other causative bacteria, like in case of pitted keratolysis or so, then we might have to do a secondary gram stain and demonstrate the thin filamentous bacterial forms. So coming to the results of our study, that is the comparison of the sensitivity. So what we identified was KOH had about 88% of sensitivity and histology about 77 and culture about 53. And this was the identification of the fungi was also there. So this was the details. So what we can see is non-dermatophytic is slowly rising over time. So coming to the discussion part of it. So like I mentioned earlier, most of the studies say that PAS, that is PAS, is having the highest sensitivity. In our study, we had very good sensitivity, but KOH was also very nearly higher. So in one of the studies, it was mentioned that KOH by an expert when it is done as compared to next pass and then KOH by resident. This was the order in which they found the sensitivity. In our study, I had a backup of microbiology team. So probably that way, if we consider maybe the values are corresponding. But what I would like to also highlight is HNE with pass positivity was present in 10 patients who had KOH and culture negative. That is, it is further increasing the sensitivity by doing a HNE with pass. In conclusion, I would like to say that nail biopsy is an important diagnostic tool in onychomycosis. So don't hesitate to do a biopsy when it is required. So the take-home message would be perform KOH first and treat if it is positive. But if it is negative, or if it is treatment non-responsive, or if it is recurrent, do a biopsy and send for culture and histology, and select the site adequately by doing onychoscopy in the process. Thank you so much.
Thank you so much, Dr. Bansal. Excellent talk. Coming to the last session of the day, which is clinico-pathological correlation, how nail biopsy actually helps. So we'll have all our experts now. So this session would be moderated by Archana ma'am, Dr. Archana Singal, who is the director professor at UCMS and is also the founder president of NSI. So welcome, ma'am.
Thank you, Khushbu.
And
so,
yeah, please go ahead.
So I'll share my screen. I think it's visible.
Yes, ma'am, it's visible now.
So thank you very much. And what we have done in last almost 1.5 hour theory and case studies, we will now have practical application of that. So it's clinico-pathological correlation, how nail biopsy helps, and it will be a case-based panel discussion. Greetings from Nail Society of India, and there is no conflict of interest. I am blessed to have the best people in the business as panelists, and Professor Dr. Sushil Tahilaini, the president of NSI, Dr. Sonal Sharma, who is an asset to have a pathologist with you when you intend to do a nail biopsy, Dr. Vineet Relhan, vice president of NSI, Chander Grover, no introduction required, nail specialist. So they have, I also acknowledge the generous, they have lent me cases generously, all of them, Dr. Chander Grover, Dr. Sushil Tahilaini, and they have excellent cases, and in fact I've cut down on mine to have theirs. So I can, I have 15 cases, but I can stop whenever you want. So we all know, just one line of introduction, that nail unit is a very small structure, and expression of any disease, both clinically and histologically, is very limited. You know, most of the disease will express in the same way clinically as well as histologically. And there is it, but the nail biopsy is very useful in delineating a diagnosis in what I say KOH and culture negative nail dystrophy. And nail unit tumor, it's a gold standard, the biopsy. And nail biopsy, whether it is nail plate, bed, or matrix, is also helpful in assigning a correct diagnosis, to explain the prognosis to the patient, and to know yourself, and to draw a treatment approach. So my first case is, I have already written courtesy Dr. Sushil Tahilaini, so there will be number of them. So this is a 40-year-old male with right big toe involvement, single toe involvement of 1 year duration. Patient is in white collar job, no sporting activity, no visits to parlor or salon for pedicure. So patient could not remember any preceding trauma. This is another close-up picture, excellent picture. So who will take up? I think Dr. Vineet Relhan has not given me any case, so he will take up this case. Dr. Vineet?
Yeah.
So what will be your approach, how you want to proceed?
Yes, come for the first time?
Yeah.
Okay. We'll try
These are the another pictures, clinical pictures, close up.
Okay, ma'am. It looks like onychomycosis, or it could be psoriatic nail also. We'll first do a KOH, nail clipping for KOH.
Okay.
And see. And if they turn out to be negative, I will do a nail plate biopsy for past staining and histology.
Okay.
But there is some element of The nail folds are also, there is some erythema present. So it looks like more like onychomycosis to me.
Which variant? TDO? The total
TDO. Total dystrophic nail. Onychomycosis.
Okay. So, sir, can you please take it forward, Dr. Sushil Tahilaini?
So I also suspected to be total dystrophic onychomycosis, also because the onychoscopy of the edge showed a ruinous appearance. Surprisingly, the mycologic studies were negative, and that is seen in some of our patients. We don't get 100% positive. And this man is well off and he wanted a result. He wanted the treatment. I could not have given him antifungal, which in a positive fungus also, it does not always work in total dystrophic nails. So I had to do biopsy from the nail plate.
And these are the biopsy pictures.
So the biopsy did show a nail plate which was parakeratotic as well as orthokeratotic, and in higher magnification, though this does not show very clearly, but even in HND you can see the hyphae, and there was also a periodic acid shift stain done, PS stain done, which showed magenta colored. You could see in one corner over here, though I wish I could show you a better photograph. A magenta colored undulating hyphae and spores would tell you that this is an invasion of the nail plate with a fungus, which was missed in the mycologic study. So that showed the role of a nail plate, nail bed biopsy in this patient to establish a diagnosis.
Dr. Sonal, would you like to comment?
Yeah, I would like to comment on this because whatever the image is not very showing us clearly any fungal elements.
But aren't they polymorphonuclear cells?
Yes, polymorphs are there. There's a lot of serum exudate also. So, because what happens is many a times fungus is also secondary. So I have to look at the base, the nail bed epithelium, what is happening there, what is the reason for this, and to be sure that that it is just fungal and not an inflammatory disease with secondary fungus. Because secondary fungus, especially when you're not seeing typical, that sandwich sign, nice hyphae, they can be secondary, especially yeast forms. They are very commonly seen. We find them almost in these, like the thesis which we did with Sumuhi and on the psoriasis and the LP, both we found, secondary fungus was frequent finding.
Yeah, I would just chip in here that when you see a solitary nail, especially toenail, and if you see a patient who might be having avascularity or trauma, then the secondary fungus turns out to be non-dermatophyte mold more often than a dermatophyte.
Yeah.
Totally. And sir, the presence of the periungual reaction, the erythema is also there. So that goes in favor of a mold infection.
NDM onychomycosis.
Yeah.
Okay, so this patient, sir, was treated with antifungals?
He was treated. I'm awaiting the results with
So great case. So single toe involvement. In fact, I would like to say that my opinion is that whenever you have a single nail involvement dystrophy, you should always have it like in two broad groups, like KOH positive and KOH negative. And even if it is if KOH positive, it's fine. But if it is KOH negative, the pass stain becomes really important. And so the onychoscopy also had a ruinous appearance. I'm sorry. So final diagnosis was onychomycosis. Coming to case 2, 24-year-old lady by Dr. Chander Grover, yellowish discoloration and distal onycholysis and subungual hyperkeratosis involving great toe nail, left side we can see, and KOH was repeatedly negative, culture showed no growth, and pass reported negative. Dr. Chander, from where the KOH was done?
KOH was done from the great toenail. From the
no, but which point? Like, because the lesions seem to be in the middle and proximal half.
Yeah, but it had distal onycholysis towards the end. And even the third toenail is involved in this case. But KOH was not done from that one. It was done from this one. Distal onycholyzed part. So like the previous case, we proceeded with nail biopsy here. And the preliminary report which came was again unremarkable nail plate, no fungus seen. But then proper DPC was done, the dermatopathological correlation, I went that I have no answer now to give to the patient. And Dr. Sonal saw these slides again, so I'm sure Dr. Sonal will now like to speak about the point that she was trying to speak about in the previous case.
Yeah, so I mean, I'm more convinced when I see these hyphae to call it a traditional onychomycosis. So yeah, here I think we can see the PS positive one, and we can also see these columns of parakeratosis, and probably it mixed with neutrophils also. So there is crust also, and there is hyphae.
So it's common, any nail plate, any onycholysis of any this thing is likely to show you some fungal spores, which are generally uneven bacteria, which are sitting on the surface, the dorsal or the ventral surface. So the key point that we wanted to just make here was you have to look for the presence of invasion within the nail plate.
Within the nail plate. So like this.
As
and like this, yeah.
And this may be sparse. I mean, you need a special stain to actually look for them, and you need some time. And at times you need a dermatopathological correlation to be done, where you need to revisit the slides or further sections or something. It's easy to report it as fungal spores seen, but fungal spores may not carry importance towards achieving a final diagnosis.
And it is very common with psoriatic nails or any dystrophic nail for that matter to have secondary colonization by yeast or bacteria.
Actually, if you look at this image with the single red arrow, on the lower aspect, you see some pink stuff sticking on. Lower, a little lower, lower. Yeah, here. So similar, this is something we see very commonly. Fungal spores, especially at where there is onycholysis happening, still like in the subungual region, hyperkeratosis.
Dr. Sonal, would you call this as a sandwich sign because it is present in between the...
Yes, this can be because it's surrounded by parakeratosis.
Yes.
One important thing, histopathology may not help you speciate like the previous.
Yeah, that we can't help.
That is the drawback.
Yeah, we can tell you with its hyphae or yeast, that's the max we can do. And yeast also, like we have reported also malassezia and all earlier in Pathology. I had done some cases. So where there also, even if it was yeast, it was nicely between the parallel to the layers of the keratin.
Yeah,
only
even
then
in
we should put it as pathogenic.
cases, like in 26% cases, there were colonization of yeast. It's in psoriatic nails. So that's also very common.
Yes, so one drawback of histopathology is it can't speciate, but the major advantage of histopathology or past stain is it actually tells you that there is fungal invasion. So just a culture positive and QH positive may not also be onychomycosis at the same time. It's just because the fungus is present there, so it is growing in culture. But histopathology that it is the positive reason for that particular nail dystrophy.
So it's very specific for, but which type of fungus it's not, but it is definitely extremely specific for with great positive predictive value.
And that can probably explain why Manasa got more KOH positivity than histopathology in her thesis work.
So the final diagnosis was lateral and subungual onychomycosis, and the learning points are that nail biopsy is very helpful in difficult cases where you strongly suspect but the KOH and culture is repeatedly negative. PAS is the most sensitive investigation, and one should look for invasion of fungus between the lamellae, and one should look keenly, as was done by Dr. Sonal on the second visit.
Can I ask a question here? Sometimes they prefer a GMS stain over a PAS stain. Could Dr. Sonal tell us the differences between the two?
GMS is also a good stain, and but traditionally we've been using PS in skin because PS is much more easier to perform, as I'm telling from the technical point of view, and GMS can be a little tricky. Sometimes it overstains. So PS is much easy, and there is internal control in PS because the glycogenated cells will give their own internal control, so you know your stain is working or it's not working. In GMS, let's say in a nail, and also GMS because it has multiple steps and heating is involved in GMS. So what happens is nail is very prone to getting washed off from the slide. So many a time what we see is that my technician will cut so many sections. I mean, many of the slides they'll get washed off because all keratin, and it doesn't stick very well to the slides. So I actually get lysinated slides cut for nail. So GM, and on heating, the sections wash off, even normal also. Normally biopsies also get many washed off. So we prefer PS for technical point of view, not for any other reason.
Thank you.
Thank you, Dr.
Sonal. Can I just ask you a question on this GMS stain?
Yes, please.
Madam, it is said that GMS stain will, the PAS will only stain those fungi which are actively active.
Correct.
And those inactive ones will also be stained by GMS. I'm not sure, but I think I read something.
Dead or
We have
alive?
seen all fungi getting stained by PAS and GMS equally. So I have never come across such wisdom.
Yeah.
I don't know. I don't think so. I don't agree.
Coming to case number 3, can we move on? So this was a 23-year-old male patient with nail lesions bilateral, both hands, as you can see, and big toes of more than 1 year. They were slowly progressive, causing nail dystrophy, as you can see. There was no skin, scalp, or mucosal lesions. He is shopkeeper owner. So what are your differential diagnoses? Dr. Shikha Bansal, can you take up this case, please? Dr. Shikha?
Yes, ma'am. Ma'am, whenever a patient like this would come to me, first of all, I'll, as it is done here, I'll examine the skin, scalp, and mucosal lesions to look for any lesions which are there which might be suggestive of lichen planus, examine other areas for psoriasis, do a onychoscopy, keep a possibility of maybe rough trachonichi or 20 nail dystrophy.
So this was done when I did not, like 2015 ka case hai, I had just got dermatoscope and didn't use it, like. So no dermatoscopy available for this patient.
And ma'am, I would have planned a nail matrix biopsy for this patient.
Okay, so as is my habit, like I always do direct microscopic examination in KH culture, it was negative. So did a nail matrix biopsy. It was consistent with, this is a clinical problem, so I'm not showing the histopathology. The nail plate nail bed biopsy was done and it was consistent with nail psoriasis. PAS was not available. So patient was planned for intramatricial triamcinolone injections because there were few nails involved. But after 2 cycles, as you can see, there was worsening of the nail lesions. Dr. Chander, can you take this up please now?
The worsening part?
Yeah, the worsening. So there was worsening of the nail lesions.
So maybe the primary clinical differential for me would have been nail psoriasis in view of the pitting and the multiple splinter hemorrhages, but so much of yellowing, though it can happen in psoriasis, maybe we missed a fungus present somewhere.
Yeah, absolutely. So the PAS was not available. Routinely, it was not being done. I think now, Dr. Sonal, we do nail biopsy if it is sent for every biopsy, right? PAS.
Yes.
But then I think we had just begun and the PAS was, this was 2015. So it was not being done and the PAS was not available for this patient. And when the biopsy showed consistent with nail psoriasis, I started with intramatricial injections, and after 2, this thing you can see there was worsening. So repeat KH culture was done. It was negative again, and it was the repeat biopsy with PAS showed fungal elements, fungal invasion. So patient was started on oral terbinafine, which was given for total of 6 months. But after 1 month, I could repeat. I restarted the intramatricial injection, and this is the response after 4 months. And this is the wonderful recovery after almost a year when patient came. So the message is that coexistent fungal elements may be seen secondary to psoriasis. This is invasion. And it's also important to know that why this happens, like this cognerization maybe, and the psoriasis went worse. Dr. Chander, do you want to explain why the psoriasis went like with fungal, the coexistence?
We are using an immunosuppressive triamcinolone acetonide being administered, which is going to stay there for some time. So that part is basically to be covered. Not all cases with psoriasis with fungal elements are going to behave like this, but this may have been a particularly severe case and promoted the rapid invasion into the nail plate by the fungus, which was already sitting there or had already started invading this particular part.
So this will also act as a cognerization for psoriasis.
Probably extra stratum corneum substrate for the fungus to grow, and improper, barrier function, so the nail fungus invades more easily because of parakeratosis.
Another part is basically triamcinolone acetonide, once you've started, is not going to show much result in the initial 2 months. So maybe over a period of time, it would have helped, and the nail, if regained sufficiently, would have been capable of throwing the fungus out on its own. But it's better.
Yeah, I would have been not been worried, but there is a visible worsening of the, see on this right thumb, there is a visible worsening. So that actually there may not be some response, but the worsening is not expected with triamcinolone acetonide, and that's why I went for repeat biopsy, and I'm happy I did that. So the point is that all nail biopsy should be dealt with PAS, because it is and it is important to ascertain if it is fungal colonization or fungal invasion, and treating onychomycosis helps outcome of nail psoriasis. So I found it really interesting.
PAS is helpful not just for the fungus, it's also very helpful because it delineates the onychocytes very nicely. So for structural changes also it is helpful.
Okay. So coming to case 4, again courtesy Dr. Sushil Tahilaini. Again monodactylous involvement, 62-year-old homemaker, dystrophy left great toe nail for 2-year duration, history of pedicure, regular pedicures once in 3 months. And she has taken many treatment, including several courses of systemic antifungal, but to no avail. Mycological studies are negative. How do you proceed? Dr. Vineet?
Again, ma'am, I think it looks like a psoriatic nail to me. So I'll do
what are the points in favor?
We can see the pinpoint bleeders are there, ma'am. We can see these splinter hemorrhages are there inside the nail bed, and
but single severe toenail involvement is pretty uncommon in psoriasis.
Uncommon.
Yeah.
And
that was the part, like
2 years duration, so one has to also be sure one is not missing on any conditions like Bowen's disease and all that. Yeah.
True.
Mycological studies are also negative.
Negative,
so
I think in TD or other, you will find very commonly that KOH and culture will come negative in total dystrophic onychomycosis. Maybe it's the whole keratin and destroyed. Is there an explanation, Dr. Chander?
The
very commonly we see
culture coming common is relatively easy to explain, as in there is a lot of debris and we are not actually reaching the live part where the infection is progressing. But KOH, I think I have no explanation for that KOH should show some spores or something.
But it does show KOH negativity in a significant number of cases.
It's a valid observation. Just like in Tinea capitis, we often inflammatory variants, we often get KOH negative.
Yeah, true. So maybe there are too much keratinous debris, and the fungus gets lost.
Maybe
too much of hyperkeratosis in that. That causes this thing.
Yeah. So Dr. Tahilaini, so this was your case.
So this was again, the dermis was lost. They only replied, the nail bed was lost. They only replied on the nail plate, which shows regular alternate tears, both horizontal and vertical, of parakeratosis and orthokeratosis, and absence of fungus, and some neutrophils at a few places.
Isn't it exudate?
Yeah, there was exudate too, and there was neutrophils also, and there were regular parakeratosis and orthokeratotic in a vertical tears as well as horizontal tears.
I think I saw hemorrhage also in the previous slide.
This one, no?
Yeah.
So this is very linear also, corresponding to the ridges. So the final diagnosis was nail psoriasis. The uncommon thing, this was very, that the single toenail involvement for so long, and I'm sure the abstinence from pedicure will also help her. So how did you plan to treat her?
I have treated the topical because she had traveled from another city in the COVID times and she could not have come regularly for intrametricial injections.
Okay. So
and I've given her tazarotene and high potency steroids 2 or 3 times.
Okay. Dr. Chander, is there any other way you would like to treat apart from intrametricial, which is not feasible in this case? So would you like to do occlusion?
Nail plate being absent, topical should work well as far as tried, and because that is the primary barrier to topical therapy in an intact nail plate. Rest will depend on, because it's a bare nail bed, it should work. Hopefully an occlusion may not be required, but it will all depend on the response, how the patient is responding.
And if there's a matrix involvement also, then matrix will not receive because that has to pierce the proximal nail fold and reach the matrix. So whenever there's a matrix signs, topicals don't work as well as when it's a nail bed sign.
Yeah, true. So case number 5, Dr. Chander Grover has contributed this single toenail involvement with distal onycholysis and subungual hyperkeratosis. Again, single toenail. Pain was there, and there was subungual collection, which pus collection, which was KOH was repeatedly negative, and the culture showed no growth. Biopsy repeated as no fungus. So what do you say, Dr. Chander, about this case?
We had basically, this was the biopsy report, no fungus. Did not tell much about what else could it be. And
what the differentials were given?
Yeah. The differentials given were onychomycosis and nail psoriasis.
Okay.
Again, because of single nail involvement, no inflammatory changes, distal onycholysis, which had a fairly regular border, but still no erythema. So you were clueless either ways, even with the help of onychoscopy. It's just that the presence of query pus prompted that I had put psoriasis above onychomycosis and had sent for biopsy, but again it required dermatopathological correlation, a DPC, and in UCMS we have a system of DPC, and in that system of DPC cases wait for some time. So the collection, because we have it once in a week, though we are sending 10-20 biopsies in a day, not nail biopsies, generally biopsies. And meanwhile the patient's disease progressed.
So this was a onychoscopy?
Yeah, this is a onychoscopy. You can see the areas of onycholysis and mild erythema in the nail bed, but no clear-cut splinter hemorrhages except for maybe the distal
ones. No spikes and no nothing.
No spikes and no erythema, not this way, not that way. So not conclusive. And but the disease kept on progressing. So you can see the split.
I can see the right side is
the mid split worsened further and like split wide open kind of a thing, and the site of biopsy is also outlined in this particular
it is there. So it's nail plate, nail bed biopsy.
This was the peak of onycholysis where I had sent the biopsy so that the plate and bed would go. And after that, ma'am, if you can show, this was the cylinder, the biopsy cylinder. And when the DPC was done, it showed very fairly typical features and too many features of nail psoriasis. So you see the presence of so many neutrophils, you see the serum globules which are present within the parakeratotic nail plate, very beautifully outlined. And literally, Dr. Sonal maybe can tell more than me, the squirting of papillae.
Sonal, can you?
Yeah. Let's start with the low power. You can actually appreciate very beautiful psoriasiform hyperplasia.
Yes.
And what you're seeing on the top, there is no nail plate. This is all subungual hyperkeratosis.
Okay.
It's all hyperkeratosis. And in between, you can see those compact area, which are actually maybe parakeratosis, probably. You know, the bluish appearance areas in the Yes. So it's all hyperkeratosis, parakeratosis. Then there is psoriasiform hyperplasia. I would have liked to see more higher view now. Go to the next slide. So there you can appreciate some amount of spongiosis also. You can see there is edema in between the onychocytes. So there is spongiosis happening. There is some inflammation also in the papillary, bits, cross sections, which you can appreciate. So there is spongiosis. You can appreciate a lot of spongiosis in this slide also. So I would like to see maybe neutrophils coating. And this is again not this PS, you can appreciate beautiful parakeratosis. And the purple band at the top is more like a serum exudate. And yes, this. And the one, these rounded pink magenta structure, this is all contaminants.
Yeah, and because the nail plate has been broken into so many layers, so you find contaminants in between the layers of the nail plate and the layers of subungual hyperkeratosis. So these are colonizers. These are the ones which are present as well. This was a higher magnification.
This probably looks like the plate. Yeah, and here you can see the neutrophils coating from these capillary. The right side one is actually showing a congestion.
Yes, this one is beautiful.
Yeah, and the left side you can see the coating of neutrophils, and you can appreciate the spongiosis. See, there's a lot of space around.
Yes, this is all spongiosis.
Yes, so spongiosis is a typical feature we see in nail psoriasis and not in skin psoriasis.
So that there we see psoriasiform dermatitis. So probably this is psoriasiform counterpart of psoriasiform dermatitis, where we can see.
No, it happens in nail psoriasis.
Yeah.
Do we also see hyperkeratosis in nail psoriasis with a thinning in the skin psoriasis? Sometimes you see
hyperkeratosis, yes.
Hypergranulosis rather. Sometimes.
Hypergranulosis is seen in nail. Yes, it is seen.
That is the difference.
Both in LP, you have a uniform hypergranulosis vis-a-vis skin where you have a bed-shaped one. And in psoriasis, compared to the skin, there is spongiosis, yes, and there is hypergranulosis, yes.
So again, the final diagnosis was nail psoriasis, and the learning points are that the nail biopsy can offer valuable clues. Clinico-pathological correlation is a must. Everyone should have a Dr. Sonal in their institute, and fairly diagnostic features of nail psoriasis histopathologically if the nail fungus is ruled out. So I think monodactylous involvement is always a troublesome area, because saying with the you can't be definite whether it is onychomycosis or it is psoriasis. And so just a supportive evidence that yes, you should do nail biopsy. This was one of the first nail cases where biopsy was done. Dystrophic nails, 2-year duration. She was engaged to be married in a year's time. She postponed her wedding because of her nail lesions. No other mucocutaneous lesion, no response to multiple courses of systemic antifungal, and repeated KOH culture was negative. So biopsy was done, and nail plate, nail bed biopsy, and it was it came out to be consistent with psoriasis. Patient is left-handed. So, that's a clue, because there is more of cobnerization. There are more of nail lesions in this patient. I asked her whether you are left-handed, and she's a homemaker, and she said that she's left-handed. So changes are more marked on the left hand. And this was the biopsy, which was consistent, and this was the treatment, intramatricial injection, because of her impending wedding. No systemic therapy was given to her. Dr. Shikha Bansal, your case, 41-year-old woman came with the pain in the right thumb, 6-month duration, which was of moderate intensity. It increased with pressure, but there was no cold sensitivity. Though love sign was positive, but Hildreth sign was negative. And you can see that the cuticle and the proximal nail fold and lateral nail folds are normal. And the nail plate shows longitudinal ridging and erythronychia. This is the, you can take this up, Dr. Shikha. What were your differentials and how did you approach?
We had kept a possibility when the patient presented with pain and nail plate dystrophy as glomus, but because the pain was not very excruciating, she was letting me touch. So I thought maybe there might be some other growth also, some other benign tumor also lying on the nail bed. So we kept a possibility of onychopapilloma in this case. This was the dermoscopy which was done, which was showing erythronychia and little white structureless area in the center.
And there is this distal splinter hemorrhage also.
Yes, ma'am. And ma'am, then we had done ma'am, I did not want to do a big punch and then a small punch. So I put the nail plate aside.
And you did the MRI also? But
yes, ma'am. There was no lesion localized. Usually in glomus or mycopapilloma, they are always able to tell whether there is a distinct lesion. In fact, I always keep an MRI film in the OT just to localize so that I don't miss the lesion. But there was just mild edema, which again told me that it might not be glomus or any localized tumor which we are dealing with. So we put the nail plate on one side. So the corresponding area of erythema was corresponding on the nail bed erythema, which was there, and a punch was performed. Ma'am, histopathology. And ma'am, in the histopathology, there were a lot of fibroblasts and thick walled blood vessels, capillaries were seen, and there were isolated lymphocytes also, which was seen. So after much deliberation, we thought that this might be a granulation tissue and the patient might have a little penetrating injury which the patient might not have really noticed, and this led to this kind of a tissue response, ma'am. And it was therapeutic. Patient came back after 6 weeks follow-up and it was totally okay.
Okay. So Dr. Sonal, would you like to comment on histopathology?
Yes, actually all I see is scar tissue, so there are like these active capillaries, small capillaries with active fibroblastic proliferating lesion. So, I mean, I would like to see myself maybe under the scope.
Yeah,
but,
I know it's very difficult.
But maybe it could be a reactive, or it might be a fibroblastic lesion, maybe a benign lesion with a lot of collagen. So on this power, I can only.
Yeah, or it could be a tissue response to the penetrating injury.
Yeah, it could be a benign, maybe I don't know if it was a clinical.
So I think
not a well-defined. Yeah.
Yeah. So the Dr. Shikha has kept confusion. It might be a tissue reaction due to some penetrating injury. Another carry-home point is every painful nail lesion is not glomus tumor. Like one should evaluate, and sometimes you need to do exploration. So,
quite right. They say even MRI will miss a glomus which is less than 2 millimeters.
3 millimeter. They say even some sir do not pick less than 3 millimeter. Yeah, like 3. So case number 8 again, courtesy Dr. Tahilaini, 79-year.
Sorry to bother you, ma'am. I think we are running short of time. We can decide how much we want.
I'll just take this fast, 2, 3, very fast. This is the last session. We can carry on. Okay. 79-year-old male patient, asymptomatic lesion, deformed nail plate on the right index finger with intermittent oozing and crusting. Sir, what were your differential diagnosis?
Knowing that he is an old person and he's had it for 3 years, and there was crusting and oozing and the nail plate is pushed up.
Yeah.
And at part it looks keratotic and verrucous also. I thought of a neoplastic growth, and I did think of Bowens as the first possibility. And then I convinced him to go for a biopsy. The
and
biopsy
this is
showed,
a nice biopsy.
Yeah, it showed dermis, except a small place where we saw epidermis, but that epidermis was good enough. We saw the basement membrane zone was intact. There was no invasion of the dermis, and you saw the disorganized nest of cells with clear cytoplasm. And this was a so-called the wind-blown appearance, which clinched the diagnosis of Bowens disease.
Yes. So how do you manage Bowens? We are not taking that. So the thing is that asymptomatic, for tumor, it is very, very important to have a histological diagnosis.
I'll just like to give 2 points here. One is that if your facility is, we should do the
markers.
We should do genotyping for human papilloma virus if it is available. And secondly, as per the granddad of onacology, Dr. Robert Baran, he says we should potentially consider all the glomus, the Bowens to be polydactylous. So we should observe these patients even after you treat one lesion. It may develop in the other digits in future.
That's a very important carry-home point. Thank you, sir. Yeah. So this is my case, 36-year-old woman, slowly progressive painless lesion under the nail plate of 6 months duration. There was no history of preceding trauma. This was a firm to hard wing-shaped nodular lesion. And I thought of subungual hyperostosis. But you can see there was no connection in the bone from the distal, and in fact there is a pressure erosion in the distal phalanx. So it was taken out by distal approach. It was a big tumor, and it was a fibroosseous pseudotumor of the digit, which is a very, very rare location. There are just few. You can see this is fibroosseous, and these are osteoblasts around a fibrovascular stroma. And this is hypar. So the final diagnosis was fibroosseous pseudotumor of the digit in the subungual location. I'm sorry, I didn't knew these are jumping. So the carry-on point is only the biopsy can give an exact diagnosis, because there are so many types of, histologically, there are so many types of nail tumors. Another case, interesting one, and this is from 2006. A 69-year-old male farmer, non-healing ulcer, right thumb, 1 year, history of intermittent pus and blood discharge, but painless. Patient had taken multiple systemic and topical antibiotics, and there was progressive nail plate destruction. So he said over a period of time, when he presented to me, it was just 1 month that the nail plate had gone. So the nail bed biopsy was performed, and radiologically you can see there is a lytic lesion, there is in the distal phalanx, and this was the biopsy, and atypical squamous cells, sheets, metachromatic nuclei, and atypia and mitotic figures. So this was reported by Dr. Navjeevan Singh then as poorly differentiating squamous cell carcinoma. The carry-on point here is that benign nail tumor often cause deformation of the nail plate, as you saw in Dr. Tahilaini's case, and malignant cause destruction of the nail plate. So if there is progressive destruction, then one should. Dr. Chander's case again. Oh, sorry, I don't know where it went missing. 45-year-old male with partial loss of thumbnail. Dr. Chander, would you like to take this?
Yeah, this patient came with a long-standing lesion with thickening and partial loss. And in fact, he said that when I cut my nail, it bleeds. So we were wondering what is it exactly, because it was very lately placed and very much destroyed. By the time he came, he actually tried cutting it with a blade, with a shaving.
The half nail plate is gone actually.
Yeah, more than half of it. So, but then the onychoscopy showed some mild clues as to what it could be, especially this, you see the multiple channels. This is the end-on view, not because hardly any nail plate was left. And you see the woodworm appearance, the presence of multiple cavities lined by the white rim. So these are multiple channels running through it. So we did a surgical exploration, and this is what we found. This
scanner
is
view.
Scanner view of the tumor removed from the nail matrix, which was in the form of a bluish anemone like thing, and this is a view from the nail plate. So the nail plate is showing those cavities with the lined by epithelium, and the tumor was showing the villous appearance with the presence of multiple fibroblasts. This is a higher magnification of that matrix tumor. Diagnosis is very characteristic with this kind of appearance of the nail plate, onychomatricoma.
Yes, so it is the triad of we have done in the dermoscopy CME already. So another case, this is different from tumor. So I thought we can stop here if it is not required. So we'll take up this case.
So we'll take up this. Okay. So this is a common condition. People come to you with onycholysis, with separation of the nail plate from the nail bed. And this one was a domestic help. She was working as a maid in multiple houses, and it was compromising her profession. She said that there is pain and she's unable to do her work. And again, KOH negative, culture negative, and even onychoscopy not helping much, as you can see. And so the differential diagnosis that we had kept here was again to rule out onychomycosis, and did a histopathology because routine investigations are not helping with anything. Histopathology showed again this nail plate, the hyperkeratosis, and you see the granular layer in the nail bed, which is present, the prominent hypergranulosis which is present, and pastine sections again. This is the normal nail plate in between, and you can see only the colonizer sitting on the surface of the onychalized nail plate. And there is hyperkeratosis, there is hypergranulosis, can't call it wedge shape. There is more or less uniform. And PAS was negative. Again, no fungal elements identified. So keeping the clinical picture and with the clues from histopathology together, we classified it as chronic idiopathic onycholysis, which is an entity seen with routine, more so seen in routine housework, and onycholysis without any associated diseases because no contribution from any of the investigations, and histopathology in fact ruled out most of the things for us. No neutrophils, no past stained specimens, no bacteria, and no abscesses, nothing.
Can it be just, you know, the cumulative insult dermatitis sort of thing? Like
yes, idiopathic onycholysis. Yes, idiopathic onycholysis is actually a cumulative kind of a vicious cycle that an onycholysis starts and keeps on propagating, just as chronic paronychia does.
Yeah.
And these two entities are the only two entities I know that we treat with triple combination creams, and her response to treatment was good.
So this I took because this is a very common condition, and every nail biopsy, what we do is not onychomycosis or psoriasis or lichen planus.
Yes.
There are other entities also apart from tumors. So longitudinal pigment, we are just 2 minutes past 5. Can we have won this case?
I think we should take, because this is one important indication for biopsy. And
because this is very scary for the parents. It's extremely scary. For adults, it's extremely scary because they Google, and there's so many patients which come because since when we have published 4 cases of malignant melanoma, there are so many patients who just want to be, you know, want the counseling. Dr. Chander, please take this.
Yeah, so this was a young child and parents were worried because of the pigmentation. A biopsy was done from the matrix, and the result, these are the dermoscopic images where you can see slight irregularity of the edge. You can see it's a through and through band, both the dorsal as well as the proximal aspect. And you can see what is known as the pseudo-Hutchinson. Children have a thinner proximal nail fold. We went ahead with the biopsy, and biopsy findings, Dr. Sonal can explain because we discussed it.
This was a nail clipping distal.
This was the actual
plate. Yeah, we can see
the matrix separated, so both of them will come separate. It's actually like putting together jigsaw puzzle together. So, ma'am, would you like?
Yeah. So basically, many a times we don't get to see all features classically what you see in books or in publications. We have to actually hunt for clues here and there and put them together. And sometimes, of course, Chander knows, she puts those clues along with her clinical findings, so we reach the diagnosis. So in this, we can see, I can see a lot of nucleated cells. Probably pigment is also visible in this nail plate.
Yes, there is. This is high power.
Yeah. So a lot of melanin is seen in this, and nucleated cells are there in the lower layer. More than a little bit, I think the epithelium is sticking to it. What happens is the nail bed epithelium also doesn't separate properly. It's not like either the entire epithelium is stuck to the dermis or to this thing. It doesn't happen like that. The epithelium itself also separates. So you can see actually the superficial layers are sticking to the plate, and the deeper layers in the next slide. So the deeper layers are sticking to the
nail bed.
dermis.
So this was a nail matrix nevus.
Yeah.
Yes. So this is another case. I'll just rush through the clinical pictures. These are parallel bands, but they're definite variegation. So I'll definitely do a biopsy, and this can be a Hutchinson sign.
So here in this age group, you actually worry.
Yeah.
This 22, 23-year-old and with the proximal spread of pigment. So here biopsy is absolutely imperative that you should do. And this is the result of the biopsy. You can see so much of melanin. Dr. Sonal, ma'am.
Yeah, so basically when we see all that melanin like in that child also, we have to start looking for the melanocyte or the nevus cells. So in that slide, we did have increased number of melanocytic clusters, but in this, we don't see too many melanocytes per se. Majority what you're seeing is incontinence in the dermis and also melanin in the nail epithelium. And that can be seen normally also, but this extent is obviously, this is much more higher. So there is just increased melanin without much increase in number of melanocytes.
So that will be okay. So increased melanocyte activity.
Yes.
That makes it melanocyte activation for us clinically, and we are relieved that there is no evidence of any malignant possibility in this particular case. And she actually, the lesion resolved on follow-up because we kept it on the tenter hooks still even after histopathology, that if it is showing signs of worsening, then we'll have to take a closer look.
Yeah, and I will tell for the benefit of our audience that in a child majority it is nail nevus, it's nail matrix nevus, and one should follow them up every 6 monthly or 1 yearly with clinically dermoscopic photographic evaluation.
Yeah.
And this is another tumor, so has been excised, acquired digital fibrokeratoma. Thank you very much. And this is the lockdown sky, so beautiful with less of traffic, less of pollution. Thank you. Thank you, Dr. Khushbu, for giving us the time.
Ma'am, thank you so much.
Thank you, all the panelists. Thank you.
Wonderful cases, wonderful. The sum of everything that we discussed throughout the afternoon. So thank you to Archana ma'am and thank you to all the panelists. So Chander ma'am, will you take it from here to give the closing remarks?
Yes. Is my screen visible?
Yes, yes.
Yes.
I just wanted to highlight in my closing remarks that I'm often asked this question about how to join NSI. So just made this stepwise presentation. Please join us. Please visit our website. There you go to the Join NSI button. And this page will open and you please download the form and communicate with us and join us. We are very happy to announce the third workshop in this series, which will be held in the month of August. We'll be sending it, it will be on ingrown nail. So it is towards the latter part of August and we'll be sending out the invites soon and the details of the program soon. And other than that, please keep discussing with us. With this, I thank all the participants for today's session. And I thank University College of Medical Sciences, Department of Dermatology and STD for cooperation and for contributing so richly to this, to the content of this particular program and helping us in knowledge dissemination. And I'd also like to thank Linux Derma Sciences for making all this possible through an educational grant. Thank you so much, and we'll see you soon.
Thank you.
Thank you so much. Thank you.